We are live.
Okay. Okay, good evening, everyone. Welcome to AIO's GuruSangam, episode 21 on oculoplasty. And I'm the moderator, Dr. Shalmati Bachao, and I would like to introduce the speakers for today's session. So, many thanks to Chairman Dr. Samar Kumar Basak and the program directors Dr. Santosh Honawar and Dr. Manoj C. Mathur, and our expert panel, uh, Dr. Bhaskar Khaire, Dr. Modini Pandarpurkar, Dr. R.C. Gupta, Dr. Reena Abdul Rashid, Dr. Tarjani Dave, and Dr. Usha Kim. And our first speaker is Dr. Arundhati Pandey from Symbiosis Medical College for Women, Pune. And she's a senior consultant and head of department, professor of ophthalmology, Symbiosis Medical College for Women in Lavale, Pune. And she has multiple specialties, including phaco-oculoplasty, squint keratoplasty, and has quite a lot of expertise in topical phaco, squint, cornea, oculoplasty, pediatric cataract, etc. And she is also a Government of India approved patent, international and national patents she has with many publications, and she is working with SCRI for a research project. Her topic today is going to be orbital cavernous hemangioma and surgical management. Um, do I have to introduce all the speakers or as they start their presentations? Ma'am, can you start your presentation?
Thank you so much, Dr. Bachao, for kind introduction. And I'm really grateful to AIOS, Dr. Santosh Honawar sir, and the whole team for this kind opportunity. Can you see my presentation?
Ma'am, you've started can you just close this and do the share instead?
Wait. I'm sharing, right?
Yeah, the share button at the bottom.
Yeah.
And just click on entire screen, not the white.
Okay, yeah. Yes. Okay. So I'll be talking about, can you see my screen?
Yes, we can see your screen, ma'am.
Thank you. Okay, thank you, ma'am. So I'll be talking about orbital cavernous hemangioma management. What I'm going to speak about introduction, then tumor itself, patient discussion, surgical approaches, management, complications, and take-home message. So why it is called a cavernous? Unlike the name hemangioma suggests, these lesions may not be tumors as there is no cellular proliferation, gradually enlarging vascular malformations, so the term cavernous malformation. In some cases, prominent fibrosis is present, and these lesions are referred as sclerosing hemangiomas. So, International Society for the Study of Vascular Anomalies, it should be classified among the low-flow, non-distensible venous malformation. It consists of thrombosed and septated venous convolution covered by a compact and strong fibrous capsule. So it is orbital tumors are classified into primary and secondary. So in which lymphoproliferative contributes 14 to 15%. Vascular tumor, they contribute 14%. So incidence of cavernous orbital hemangioma is approximately 4 to 9% of all tumors. One of orbital vascular lesion. And again, it is a vascular malformation. And etiopathogenesis, it is said that it is a ectatic aging vessels. So how do we classify? Primary tumors of orbit, they are classified according to the origin. So they are classified into mesenchymal, epithelial, and neural. Mesenchymal, again, they are divided into hemangioma, lymphangioma, fibroma, rhabdomyosarcoma, undifferentiated sarcoma, reticuloendothelial tumors. Epithelial, they are lacrimal gland epithelial tumors and carcinomas. Neural, they consist of neurofibroma, neurolema, glioma of optic nerve. So what is cavernous hemangioma? It is a solitary encapsulated venous lymphatic malformation, that is cavernous venous malformation, slow flow venous malformation, commonest adult benign primary orbital tumor, second most cause of proptosis after thyroid related orbitopathy. It is commonly seen in females, and generally it is seen in second to fifth decade, but the most common presentation, it comes in a fourth to fifth decade, and 80% of the tumor, they are intrapugnal. So what does it have? There is a gradual painless axial proptosis followed by unilateral solitary growth. There are developmental hamartomas. They are seen like a spherical. They have a shapes of spherical, oval, or lobulated. What are variants? So fibrous, red, and mixed color, depending upon which content they have more. So if they have a fibrous more component, they will look more whitish. And if they have a more blood-filled cavities, then they are more like a red or the brown, the chocolate brown color. They can present as a papilledema or choroidal folds. Gaze-evoked transient blurring of vision may occur, and even patient may present as a visual field defects. So pregnancy accelerated growth is seen with hemangiomas. So I'd like to discuss this patient. He presented to our OPD. So 54-year-old male visited ophthalmology OPD. Proptosis of left eye since last 6 months, and it was progressive, gradual progressive. He had a swelling of left eyeball since 15 days. He took steroids elsewhere, and then he presented to our OPD. There was no history of DOV, headache, vomiting, weight loss, or any thyroid deranged levels, or no history of diabetes mellitus. There was no history of trauma, smoking, alcohol, any noise in the head, no change in the position of the proptosis after bending down, or a Valsalva maneuver. There was no negative, family history was negative. So his clinical finding were visual acuity 6/6 both eyes, near vision N/6 both eyes, and he presented with the left eye. So color vision was normal, pupil were normal. Generally, this proptosis, or they may present as RAPD, but he did not have any RAPD, that is relative afferent pupillary defect. Shermer test negative, anterior segment normal, and his fundus was absolutely normal. No choroidal folds were seen. Cranial and ENT examination was absolutely normal. So these are the pictures. You can clearly see that there is a left eye proptosis, and this is axial proptosis. This is a side view. Again, in this picture, this is axial proptosis, and there is a even lower lid fullness is seen. On the palpation also, this was more tense as compared to right eye. So there was a 30 millimeter of proptosis was seen. So we admitted this patient and did all the investigations. Yeah, one more view. So again, left eye, it is clearly marked that this is a clear-cut axial proptosis. His fields were absolutely normal. So MRI done. In MRI, this is a well circumscribed sheathed mass is seen. It is a hyper intense on T2 image. In all the scan, it is very seen clearly, and it is more inferiorly and more towards near to a lateral rectus, and it is an intraconal mass. So well circumscribed encapsulated mass, hyperintense. The size was 2 centimeter by 1.5 centimeter on T2W. So how do you classify on what are the clinical features of hemangioma, cavernous hemangioma on MRI? On T1, it is iso-intense compared to muscle. If areas of thrombosis are present, Then hyperintense may be visible due to slow flow. T2, hyperintense compared to muscle, may have low intensity septation. Pseudocapsule is of a low intensity. And T1C, that is GD, a slow, mild arterial enhancement with progressive fill-in and subsequent homogeneous or heterogeneous enhancement on delayed phase is a classical characteristic of hemangiomas. So well circumscribed homogeneous tumor. B-scan was, then what does B-scan show? Good sound transmission with moderate internal activity. What are the differentials of hemangiomas? Are fibrous solitary tumors, optic nerve glioma, optic nerve sheath meningioma, hemangiopericytoma, which is a malignant presentation. So investigation, all the investigations were normal. His blood done normal, urine was normal, triple H was normal. Only during investigation, his serum sodium levels were 132. So physician gave him a normal saline and the sodium tablets. So on the day of surgery, he had 140 levels, so it was normal. So what is a plan of management? Generally, where we do a conservative management. See, in this patient, the patient had a proptosis and it was a gradual proptosis. But if the patient is having no proptosis, no complaint, and if it is an incidental finding, generally it can be managed with with a conservative management, but regular follow-up with MRI scan is must. What are the indications of surgery? Proptosis, optic nerve compression, or there is a RAPD is seen. It could any decrease in the vision, visual field defects, and diplopia. If the patient is coming with the diplopia, we have to discuss the surgical option with him. So what are the incisions? This coronal is done by neurosurgeon commonly. Then proline, then stellards. Even we can approach through upper lid or lower lid or laterally. So what are the anterior arbototomy location is anterior, medial, lateral, and inferior. What are approaches? So anterior eyelid, that is anteriorly we can go to reach the orbit, eyelid crease, subbrow incision, transconjunctival. Generally, it is done with the inferior transconjunctival incision, then transcutaneous, lateral canthotomy or lateral orbitotomy, then vertical lid split orbitotomy is also done, and transcaruncular when there is a tumor is on the more on the medial side. So these are the other approaches. So stereotactically assisted craniotomy, commonly done by neurosurgeons, and transnasal endoscopic orbital surgery done by ENT people. There is again one technique, so adjunct aspiration technique for the surgical management of deep orbital cavernous hemangioma, where blood is aspirated, then they may reduce the size of the hemangioma and then they remove the hemangioma. What I did in this surgery is a lateral canthotomy or a lateral orbitotomy. Lateral approaches was first described by Crolin and modified by Burke. I would like to show this video. So this is done under general anesthesia. Okay, and in the lateral canthus, it is infiltrated with lignocaine, with bupivacaine. Then incision is marked till lateral orbital wall. I prefer to take incision with a side port. Incision is deepened. Inferior and superior crux also removed to get a more exposure side. What is used to control bleeding? So till I went till the lateral orbital wall. This is a lateral orbital area. So removal of made the more space actually. Then lateral rectus muscle is separated. This is the, so lateral rectus muscle separated and then the blunt dissection is done. Sorry. Okay. I'm sorry. Okay, now this blunt dissection is done. Okay, now beauty of this tumor is we can feel the tumor. I mean, I could feel the tumor inside, but I could not visualize it because it was in the deep in the, it was in the orbital apex, okay, posteriorly into the orbit. So I inserted my finger and with a slow movements around the tumor, I got the tumor out. Okay, it took around 5 to 10, 15 minutes to take the tumor out, and it is called as a finger insemination technique. I'd like to show that technique here. Yeah, see now I'm finger inside. Okay, my index finger is there inside. I'm just moving, rotating my finger around the. I could feel the tumor. Okay, now the tumor has come up. Okay. See, this is the hemangioma, then lateral rectus. Again, sutured back to its position. Please take care of the cornea while operating because I use visco. Conjunctiva again sutured with a 6-0 vicryl. And lateral canthotomy sutured in 2 layers with the help of a 6-0 vicryl. Pressure pass was given for this patient for next 2 days. And antibiotic, anti-inflammatory started. After 2 days, the patch removed. There was no swelling, except he had a upper lid hematoma, mild hematoma, and it. I mean, within 1 week, he came back to normal. So, according to this reference, lateral orbital wall is a safe approach. So how to remove tumor is a finger insemination technique. Again, few people, if you see the tumor, okay, then the cryoprobe can be used, and even clamp is used. So with the clamp, there are chances that it may break, and breaking in the piecemeal, it is possible. If there is, I did not break the bone actually, you must have seen. So if you break the bone, the lateral orbital wall, you get a more space to operate. So in transconjunctival approach, there is no bone removal, no cutaneous incisions, shorter operation time, and lesser trauma to orbital structures. So again, this is the size of, this is the tumor. Okay, I wanted to just show the comparison, the eyeball size and the tumor size. It was 20 millimeter by 15 millimeter. Yeah, this is the size. So this was a histopathology, multiple dilated, thin-walled blood vessels surrounded by fibrocollagenous stroma. It is very easily seen, and this is only hemangioma. One more slide of this is the histopathology report. So it is an encapsulated nodular mass composed of dilated cavernous vascular spaces separated by connective tissue stroma. Flattened endothelial cells line the vascular spaces which are filled with blood. 1 to 5 layers of smooth muscle cells surround the vascular spaces. Generally, no infiltration of any cells is seen, but few reports have mentioned infiltration by lymphocytes. So this is a teamwork. The patient under GA, he came out easily. Post-op recovery was really good. I'm really thankful for this team. So what are complications of surgery? Lead hematoma, visual loss due to damage to central retinal artery, third nerve palsy of superior branch, mydriasis, and hyperopia. Before the surgery, actually, I counsel patient and relatives about the pros and the cons. Especially, I mentioned about the central artery damage. And this was a major risk in his case because it was a typical intraconal mass. Again, a few more complications, diplopia because of a muscle injury, surrounding tissue like optic nerve injury, muscle injury, and incomplete removal it can come as a piecemeal, in a piecemeal. Then spontaneous hemorrhage from orbital cavernous hemangioma resulting in sudden onset of ophthalmopathy. Case is reported. It can present as osseous lesion involving orbital bone or as a tumor within the lacrimal gland. So take home message, thorough evaluation with all scans, okay? How much is the prognosis, what is your diagnosis is very important. Even consult radiologist, your radiology friend for even detailed evaluation. Detailed counseling and discussion with patient and relatives is must, because pros and the cons you should explain to patient and give your 100%. So I'm really thankful for this opportunity and thank you so much.
Thank you, Dr. Arundhati, for great video and presentation. And I wanted to ask you, what are the different methods that you used for hemostasis, as hemangiomas are known to bleed. So what pre-op, intra-op care did you take?
Yeah, so actually his BP was his BP monitoring was done very crucially, because I was asking my anesthetist. Then he was not a case of the hypertension and aspirin. Even if he is any blood coagulating tablets, then I will stop those tablets. And the thorough physician examination is must. And the cautery was ready, and even the suction was there as a precaution during surgery.
Okay, thank you. And do our expert panelists, Dr. R.C. Gupta and Dr. Tarjani, have anything to add regarding?
Yeah, Dr. Pandey, fantastic management of the case. I enjoyed seeing your video. Just had a few small comments. Cavernous hemangiomas are vascular malformations that are a delight to operate and remove. They generally don't tend to have fibrous adhesions to the surrounding like you'd expect in a hemangiopericytoma or a schwannoma, which, presents similarly. They try to kind of, squiggle out of very small spaces, and therefore you don't require very big incisions. Just few things that I probably do differently is I don't disinsert the muscle. I use right angle retractors, and of course you need a lot of assistance in orbital surgery. So I tend to have two assistants on either side with two right angles with which they expose the plane in which I want to go. Here it was between your lateral rectus and inferior rectus. So just putting those two Langenbach's retractors inside takes you directly from the extracornal to the intracornal space. And then once you're able to see one pole of the tumor, you kind of confirm your diagnosis, the look, the appearance, that purple violaceous hue of a cavernous hemangioma is difficult to miss. It immediately you can differentiate it from a schwannoma, or for that matter, a hemangiopericytoma also. The minute you've seen that appearance, you know that this is a cavernous hemangioma in your mind, and then you just bluntly dissect the planes around and give it a little bit of cryotraction or traction with any instrument, and it just pops out beautifully. So that's that one little difference in what I do. I tend to avoid touching the muscle, and with that I've noticed that post-operative recovery is faster, diplopia is lesser, and they tend to do very well.
I tried to visualize the tumor, but I could not visualize the tumor.
Yeah, so just using two instruments to bluntly dissect the fat over it will show you the anterior pole. So if you use a lens spatula and a periosteum elevator, obviously in the orbit using your hands is difficult because the space is limited. So you use these two instruments to gently dissect. And once you have a visualization of one of the poles, then you can go ahead and plan the rest of it accordingly.
Okay, thank you so much, ma'am.
I agree with Dr. Ajni that actually this cavernous hemangioma is comparatively very easy to get operated, because we for postgraduates we start that if they're superficial, then of course PGs can also do. So there is no need of actually disinserting the muscle. You just retract them and just reach over the surface of the tumor. And then if it is not if it is very, very, very posterior, then we put just a cryo probe and just give a little bit traction. It will very, very easily, it will be dissected and it will come out. So that is our experience. And I think the all among all these orbital tumors, I think cavernous hemangiomas are very easy to, most easy to get operated.
Yeah, sure.
Okay. Okay, thank you, Dr. Arundhati. And I will now be introducing the next speaker. Uh, do you have anything else to add? Because regarding the presentation or such?
Just
Dr.
have
Arundhati?
one more point to add that for those tumors which are apical at the very apex posteriorly, one of the approaches, like Dr. Pandey mentioned, is an endonasal approach to excise the tumor. But you also now have in your armamentarium the option of stereotactic radiotherapy, which kind of shrinks the tumor, and therefore you don't need to go chasing it at the apex where third, fourth, sixth, second cranial nerves converge, and therefore you'll avoid complications. There's also a case report on injection of VEGF into cavernous hemangiomas. Essentially, Avastin is what has been used, and that is also shown to shrink apical hemangioma. So these are two options for tumors that are really posterior apical and possibly also have some intracanalicular involvement along the apex. So these are handy.
Can I add a point?
Yeah, please do. Dr.
Hi. Thank you, Dr. Pandey. That was a fantastic talk. Like Dr. Darjini said, like those apical tumors have either a pear-shaped configuration or an apple configuration. So if they are pear-shaped, then that has a higher risk of vision loss as well. So that is something that can be beautifully understood on imaging, and then we can plan accordingly. Also, no longer are hemangiopericytomas a part of the cavernous malformations. They have been classified pathologically under solitary fibrous tumors, and they are a complete different sect of management options and how we treat them. And it's a very evolving concept. So, yeah, these are the only 2 pointers that I want to add. But fantastic. Thank you so much for the lovely discussion.
Thank you so much.
Yeah. Thank you, Dr. Arundhati. And I will now be introducing our next speaker, Dr. Ruchi Goel. Yeah, so 1 second. Yeah, can you see my screen now?
Yes.
Yes, please go ahead, Dominic.
Yeah. So introducing Dr. Ruchi Goel, who really doesn't need much of an introduction. She is known for her publications in oculoplasty, especially her manual of oculoplasty. She is the director, academics, quality control, healing touch, super specialty eye care, and visiting consultant at Rajiv Gandhi Cancer Institute and Research Center, and the ex-director and professor at Maulana Azad Medical College, New Delhi. She is also an FRC Optal examiner and also a reviewer of many national and international journals such as OPRS, Orbit, Cornea, IGO, BMJ, Clinical Ophthalmology, Saudi Journal of Ophthalmology, Eye, Current Eye Research. And she has more than 100 index article in journals, more than 33 book chapters, 3 CME series by AIOS, which I'm sure people must have read, and manual of SICS as well. She has also won multiple academic awards like the VP Chadha Memorial University Gold Medal, Rukmini Bai Gopalakrishnan Memorial Gold Medal, the AIS APAO Honavar Award for the Best Paper in Lacrimal Session, and AIOS IGO Silver, an outstanding paper by the International College of Surgeons. So,
Hello everyone, I will be sharing my screen now.
Yes, please go ahead, Dr. Ruchi.
Can you see my slides?
Yeah, doctor, can you just make it full screen and start the PowerPoint show, please?
Yeah,
All
we
good,
can see
doctor.
your screen. Yeah, that's great.
Okay. So, hello everyone once again, and I think most of the part of my presentation is kind of an overlap, but just to go into the details of different techniques of orbitotomy, I'll be discussing few of the tumors and showing some videos also. And as we know that the orbital lesions could be neural, vascular, mesenchymal, lymphoproliferative, histiocytic. They could be lacrimal gland tumors, metastatic tumors, retinoblastomas, cysts, and there are so many different varieties that we have that we may have to decide whether to go for an incisional biopsy, an excisional biopsy, or we may even require an excision. Now, whenever we talk of, as to what the planning is, first we have to see where exactly our tumor is located, whether it is well circumscribed or it is diffuse into the orbit, how close it to some critical structures in the orbit, which quadrant of the orbit is the tumor located, whether in the superior, inferior, medial, or lateral. Again, when we talk of the orbit, we always divide it into three parts: the anterior one third, the middle one third, and the posterior one third. As we were just now discussing, tumors which are located in the posterior one third, that is NPI shaped tumors close to the orbital apex, these are the ones which are the most difficult to remove. And often we may need some additional adjuvant techniques to remove them, or take help of our ENT colleagues or sometimes neurosurgeons to help us out. The extracorneal masses are much easier to remove, and especially those located in the anterior one third are the easiest. Now, just going through the different incisions that are used, they were kind of mentioned initially, but I'll just go through more details now. So when we talk of orbitotomy, it is either the anterior orbitotomy, and tumors which are located in the anterior one third, especially, they are taken out by anterior orbitotomy. The transcutaneous approaches in the upper lid would be upper lid crease incision. In the lower lid, it is the subciliary incision and again the crease incision. Nowadays, most of us try to go through a transconjunctival route, but lesions which are a little they are located at a depth, and whether in the superior or the inferior quadrant, but they're extracorneal in location. Sometimes it is much better to go in for vertical lid slit for the upper lid, although it does leave a scar, but it gives a very good approach to the deeper lesions, and a swinging eyelid crease incision for the lower orbital lesions. Talking about the medial incisions, here we can again have transconjunctival incisions, and then there could be transcaruncular. This is the Lynch incision, which is midway somewhere between the medial canthus and the nasal bridge, and this is the Gullwing incision. Now, the lateral orbitotomy incisions, just to summarize the history, how we started, again, different people have different priorities and preferences. And not only that, sometimes, despite all our, cosmetically nicely planned incisions, we end up enlarging our incisions because when you're taking out the tumor, it is more important that we take out the tumor in totality rather than just focus on the cosmesis. So this is the initial corneal incision, and it used to be cosmetically not a very nice incision. So the concavity was changed, and this is the modified crinoline. This incision did not have a very good exposure, so T was added to it, so it became a T-shaped incision. This is the Burkiss incision, which Dr. Pandey had just shown. And then this arm was tilted upwards to get to be hidden in the spectacle arm. So this was the Reese modification, and these are, of course, the incisions. Uh, these are the hairline incisions. Most of us, however, like to go in for the upper lid crease incision nowadays. Other than that, of course, depending on your tumor, you may go in for a coccus incision and a stellar right, which is again a very standard incision, gives very minimal scars. So just going through a few disorders Now, in lymphoproliferative disorders, where we have a diffuse mass which is conforming into the, we just need to take a specimen for a diagnosis. So sometimes an FNAC suffices. Otherwise, you can just take an incisional biopsy from anywhere. Transconjunctival route is the preferable one. Then there would be mesenchymal tumors, where again we just need to go in for incisional biopsy. This is another sarcoma. There would be some tumors that would require just not the biopsy is required after initial biopsy, you need to do a debulking. So this is a transconjunctival approach where the lateral rectus has been hooked and the tumor is removed and the debulking is done. This is, of course, after multiple stages. This is the look after 2 years. This patient appears now like this. And these are slow growing tumors. So the more you do a debulking, better the prognosis. Fortunately, she still has a tumor free period after 2 years of this debulking, and you can see this tumor was limited to the anterior 1/3. Now, just now we discussed a lot about vascular malformations, but again, there could be various types of malformations. It could be primarily arterial, primarily venous, it could be lymphatic, or it could be a combination of these. The lymphatic malformations are no flow malformations, and again, they have to be differentiated. They could be a mixture of lymphatic and venous. The characteristic feature of a venous malformation is a positive Valsalva maneuver. You would be tempted to remove this mass because this is lying quite anteriorly. But when we did a color Doppler, we found that there were a lot of arterial waveforms as well. So in this patient, we decided that first the arterial component either has to be embolized and then you go in for surgery. Otherwise, directly, if you start your maneuver, you may end up with a lot of bleeding. So this is one thing which one has to be very careful when you're dealing with vascular masses. This is a typical lymphatic malformation. Again, proptosis, you see, if you do an ultrasound, if nothing is there, you immediately pick up these large spaces. So all that is required is that you aspirate this, inject sclerosing agents. Choice may be yours, sodium tetradecyl sulfate, or you may go for bleomycin, whatever. All of these work pretty well and are easy to inject. Now, this is another a young adult who presented with a mass in the inferior orbit, and you can see it's quite superficial. Again, it clearly shows there is not much of proptosis. It is becoming prominent when the patient is looking up. So it appears to be most of it is in the preseptal area. So one can go in for a anterior orbitotomy again. And you can see the scan here. It is going somewhere till the mid orbit, but most of it is in the anterior 1/3. So you can use either the conjunctival approach or you can go in for the skin approach. Now, the other thing is that you cannot see the inferior rectus separately. So it is better that whenever you are not sure, you always hook the muscle which is in that area so that you don't accidentally damage it. This is a subciliary incision which was given, and very carefully you have to dissect all the adhesions. So what is important here is that you should not traumatize the capsule of the tumor. But however, this was not a pure cavernous hemangioma, and you can see there is a lot of fat in it. So it was actually a combination of a fat and a vascular malformation. So this patient was so you can see after removing a part of it, the fat had to be this vessels and fat has been cauterized, and lot of cautery is used every bit so that you don't cause lot of bleeding. After using the cauterization, the fat portion has more or less shrunk. And after this gives again not a cosmetically very disfiguring scar. It gives a nice post-op appearance. This is another patient. Now see the difference here. Again, the tumor is located inferiorly because the globe is pushed up, but there is a lot of proptosis also. So this indicates that this tumor is going far posteriorly, and we'll just see the video. So this I have removed by a swinging eyelid crease incision. This is a very nice approach to tackle deeper tumors. So horizontal incision is made. Again, care has to be taken to hook. Now this is the inferior rectus which has been already hooked, and it also helps in pushing the globe up. Also in between one has to be careful, just keep a watch. See, this is again a blood filled tumor, and it has a lot of adhesions. Possibly the patient has had multiple hemorrhages, and then the adhesions had formed all around. So very carefully one has to pull it out. Sudden pulling and pushing may cause bleeding into the orbit, and also in between pressure needs to be given and the pupil needs to be washed so that you know that there is no compression on the optic nerve. And this is the lateral canthus that has to be reconstructed at the end of the surgery. Now, this patient, again, this was a vascular malformation, but the location, as you see, it's on the medial side. So laterally, it is, we all like to have tumors located laterally, but medial tumors are very difficult to remove. And the options, you can see already the patient had, the vision was, there was proptosis. The vision had dropped to 618, and you can see there is an optic disc edema that is already set in. So option one, send it to your ENT colleague. It is easier to remove through an endoscopic route. The other option was that you tackle it yourself. So the patient wanted that it to be operated by us only. So we first decided to go for this is a medial rectus now being hooked, and this is the transcutaneous incision that I decided to go for. However, the tumor was so large and I just could not get a very good view, and the adhesions were so strong that I had to, actually cut the medial canthus, and this was something which was unplanned. First, we thought I'll do a, punching of the anterior lacrimal crest, but then I got a good uh, approach after dissecting a little, and the tumor, you can see again, is being mobilized. I have not, these tumors where you don't have a very good encapsulation, I usually don't like to use cryo because it gets ruptured midway and starts leaking. So only in patients where they're very well encapsulated tumors, I like to use cryo. This is just a blunt push with the lens spatula, and after the a good layer to layer suturing was done, and this is the post-op appearance. Now the neural tumors, again, they can vary from, now this is a young girl who presented to me with upper, or there was a periorbital superior fullness, and getting this MRI done, I found that this tumor was not limited to the anterior portion, but it was going way beyond till the orbital apex, and this was actually a frontal nerve schwannoma. So in the scans itself, so these tumors, besides the bleeding and, besides the trauma to the orbital apex structures, counseling has to be done about the post-operative anesthesia that the patient would have in the forehead region and the scalp region, because they get very upset because due to that. In this case, it was not possible to remove this tumor simply by using a upper lid crease incision. I needed to have a direct visualization of the depth of the tumor. So I don't have a video, but I went in for a vertical lid split. This vertical lid split, you can see it does cause a little bit of scarring, but then here it is more important to preserve the structures rather than causing scars. I gave her an option of going to the neurosurgeon. However, she came back and she said, I would rather go for a lead approach. So that is how you can go about with these tumors. This tumor again, a schwannoma, and it was a large tumor, more than the size of the globe, and it was located bang into the intraconal area. Here, there is no way of approaching it through any of the interior routes, and the only way is either you go in through a lateral orbitotomy. So that is what we went ahead and did, and this is a typical stellar right incision. It was such a large tumor. I was not looking for any cosmesis. I was more interested in taking out. And this is the periosteum being incised. And I needed a large bony window and 3 to 4 centimeters. So I did a typical, the classical bone was reflected the lateral orbital wall. and this is just 3 millimeter above the frontozygomatic suture, and the lower one was till the floor of the orbit, and you just reflect it through the suture between the zygomatic and the greater window of sphenoid. The tumor immediately comes into view, and again, very carefully, very slowly, you have to remove the adhesions, and a lot of blunt dissection is required. Once the adhesions are partly removed, you can just again either put in a lens spatula or your finger or whatever, and just gradually push the tumor out. One has to be careful not to pull very fast, otherwise again they may be, because it would have some vascular supply, and you may end up causing a central retinal artery damage. So you can see there is the lacrimal gland on top of it, which is again has to be protected, and all the adhesions have to be removed very carefully. And once the tumor is removed, the wound is closed in layers as usual. The bone just has to be reflected back and nothing much has to be done about it. Now, this is a young boy who presented to me with again an intracorneal mass, but here you can see the difference. The mass is extending right till the orbital apexus. This is the typical pear-shaped uh, mass which we were talking about. Here, we don't really need to do a biopsy in these cases. These are very typically diagnosed by the imaging itself. And this patient was underwent radiation and is still under follow-up. Now, just to talk about the lacrimal gland tumors, a pleomorphic adenoma, as you can see, it is a very typical. It gives presents a slow growing mass with a typical S-shaped deformity, fullness in the lateral orbit, superior orbit, and you can see a very well-defined mass sitting very quietly here, very easy to remove, and you can see a very well encapsulated mass is there. Contrary to this one, you can see this picture, a rapidly growing mass with pain, and you can see some sort of bony erosion over there. And this is a patient where, if classically, when we talk about pleomorphic adenomas, we say that we do not injure the capsule because there may be chance of malignant transformation. But here you suspect that there is a malignant already it's a malignant tumor. So you must keep advise the patient even after the surgery that patient has to undergo radiotherapy. Now, just to show how to remove this is a case of pleomorphic adenoma. So here, after a good retraction, the masses can be easily seen. Sometimes if you are not able to get the the mass is not getting mobilized and you want a better view, what you can do is you can simply punch the superior orbital wall like Dr. Goldman had described. And this gives a very good approach to the tumors in this area, the supralateral part. The important thing is that again, you need to be careful with the capsule of the lacrimal gland tumors, not to injure it, not to leave behind pieces. And I'll just show you. This is a boy, young boy, 2012, a very well done lateral orbitotomy. You can see there was no damage to the mass. And unfortunately, he came back in 2019 with a recurrence in the mass. FNSC confirmed it to be a pleomorphic adenoma recurrence. He was advised radiation. He disappeared. And then he comes back again in 2022 with this kind of a picture. So one has to be really careful. Unfortunately, by this time, the patient had developed carcinoma ex pleomorphic adenoma. So these patients sometimes they may have small adhesions which may be clinically not apparent. So all these pleomorphic adenomas, they should always be kept under a follow-up for long, and you should not just think it's the end of the story. Another case of a lacrimal gland mass did not appear to be on radiology, doesn't appear very suspicious, but he had a very short history and it was rapidly progressing and there was pain. So these are the signs where you need to be very careful. The biopsy, normally you need to take it out in toto. The biopsy was, the surgery was attempted elsewhere and they found there were a lot of adhesions outside the gland, and they kind of just took a biopsy and sent it for histopathology. It came out to be salivary duct carcinoma of the lacrimal gland, and on PET scan, metabolically active tissue was also seen in the intraparotid lymph node. So finally, this patient underwent exenteration with partial parodectomy, and level 2 lymph nodes were removed, and now is undergoing radiotherapy. This is my last case where, this patient presented again with a superior orbital mass, and on getting a scan done, I realized that this mass is not limited to the orbit. You can see it was a mucosal which was presenting like a superior orbital mass. So the message is that whenever you have these kind of patient, always look at the adjacent structures. The mass may be arising, may not be limited to your orbit. It may be arising from the maxillary sinus, all these sinuses, or it could be any, even intracranial masses otherwise can present as orbital tumors. So you should always be very careful when you are planning your surgery. Now, just to, recapitulate what all I have talked about, you can see this mass is a nice mass, well circumscribed, sitting quite in the anterior and the middle third, can be removed by any of the techniques, the transcutaneous or the transconjunctival approach. This mass, where it is going and it is in the middle and the posterior one third, one has to be careful that you need a good approach. So it is better to go for either a swinging eyelid crease incision, which would give a good, or sometimes you may again, require help of your ENT colleagues to go through the sinuses and remove this. Now here, this is again a superior orbital lacrimal gland mass. Only care has to be taken that you remove it in totality with all its capsule intact to prevent a transformation into malignancy, but at the same time follow them up very closely. This patient with a superior orbital mass going well back, it is better to go for a procedure like vertical lid split, where you get a good view far back. This mass, which is sitting mostly in the posterior one third and the middle one third, there is no way of doing an anterior orbitotomy. Always go for a lateral orbitotomy. These masses are best taken out. Either you can go for again stereotactic radiation, or you can take help of your neurosurgery colleagues. And always go in for image guided complete assessment before you go in for any surgical procedure. Take help of, don't shy away from taking help of your neurosurgeons, your ENT colleagues, and you need to discuss them well with your radiology colleagues to understand exactly what the mass is supposed to be. We can go in for cosmetically acceptable incisions, but if need be and you need to take out the tumor without injuring the adjacent structures or the tumor capsule, you can extend the incisions, and you may need combined orbitotomy approaches also. Meticulous dissection, preventing damage to intraorbital structures, especially the muscles adjacent to it, are very important. During the surgery, it is important to keep pressing, removing all the blood, checking the pupils so that you are sure that you're not injuring the optic nerve or the central retinal artery. And these are just the tips I wanted to add. Thank you so much. I'll be happy to take any questions.
Thank you so much for such an excellent lecture, Dr. Ruchi Goel. We have read your multiple articles and books, and I think having you in person discussing all these cases with you has been incredibly helpful. And so I would like to ask all the expert panelists if they have any questions or such to ask.
Dr. Ruchi has covered almost all the spectrum of the orbit, and as she has been very nice, very good academician, good covering all the aspects of orbital surgeries. And as she rightly said, that this is very important, that when I started doing orbit way back in 93, then I used to sit with radiologists for hours together, because doing orbit without knowing exactly the extent of the tumor, the type of the tumor, the adjacent structures nearby the tumor, it is during the surgery you can be, of course, in big problem. So that is very, very important. And this is also very important that we should not be hesitant to take the advice of your ENT or your surgeon's colleague. There is no, because actually ultimately we are all working for the patient, to benefit of the patient. So if there need be, we should not hesitate to ask. And of course, the very important thing, most of the rather some fortunate things about the orbital tumor is that most of the tumor they are capsulated. So capsulated tumors are easy to be taken out. At the same time, the diffuse tumors, of course, which they are difficult, and of course they had to be, before taking for the surgery. Of course, one has to be very cautious, very careful, and take the advice of the colleague if it is needed. So thank you, Dr. Ruchi, for taking this type of lecture. And thank you so much.
Excellent presentation, Dr. Ruchi. Congratulate you on all the lovely cases you have demonstrated and done. And I love the way you use the spatula to wobble the tumor out. I do it with my malleable copper retractor, smallest size. I go all around the tumor and then just try to push it up. But cryo also has worked quite well. And like you said, yeah, sometimes there's a risk of rupturing. The biggest challenge to remove a deeper tumor is how to hold it, and separate it from everything. And the technique you showed is what most of us end up doing with different equipment. I shall try the lens spatula because it is thinner and smaller and not so long. Copper, you have to really bend to the right dimensions, and the length obstructs you sometimes. Excellent presentation. Also wanted to get the opinion of the expert panel on whether anyone has seen a transitional cell malignancy in a lacrimal gland. I have not even, I mean, I have a case which has come back as a transitional. I did a biopsy, wondering it's adenoid cystic carcinoma of the lacrimal gland, and it comes back as a transitional, which is a little, I mean, it's confused me. So I'm just waiting on the IHC, but I just wanted anyone's input if they have it. Did not find any literature on it. Any inputs, Dr. Ruchi, Dr. Sonam?
No, ma'am, no,
No,
not.
ma'am.
I haven't had.
No, we have not come
Dr.
across.
Sir, I
Yeah.
have not come across any literature either. I've come across literature in the lacrimal sac, transitional in the lacrimal sac and the NLD, but have not come across in the gland. And trying to find whether the patient, the tumor, the growth started. Now it is enveloped the whole orbit. So it.
Can you take a second opinion of some other histopathologist?
Sir, I'm waiting on histopathology. I'm waiting on IHC, sir.
I think that would be better.
IHC will give me a correct picture, because
Yeah.
I just took a biopsy. The tumor had crossed the midline when case presented to me. She had a biopsy taken, I think, about 15, 20 years back elsewhere, and just had some small photograph of a report with her, which said pleomorphic adenoma, and now it did not come back as that. I suspected a malignancy, so I went in and I was quite surprised to get a report of a transitional cell, which I just wanted to ask people if they have ever encountered anything like that, so that I know how to deal with my case. Anyway, after I get the IHC, I'm planning to go in and do a excision, oblique excision, depending on how the tumor is really involved, the other ocular structures, because we can only see that much on the MRI or the CT. We can't see really what is there on the table exactly.
That's very interesting, ma'am. We've had like you correctly said, we had one which was coming from the sinus going into the medial orbit. And we had to debulk it and then send it and further underwent a further removal of the entire walls of the sinuses along with our max fax and ENT colleagues. So it was quite an extensive surgery, and then received some RTR post to that. So that was the only case that I can think of.
No, I have not seen of the sac either. Never encountered it. My pathologist has already taken a second opinion from the HOD of pathology at the medical college. And then that's why we sent it to IHC now to confirm it. I don't know what will come out. Let us see. One more thing I wanted to add here on a lighter vein, that every time you go and tackle a deeper orbital tumor and it comes out, you feel like a Superman. I feel like a Superman. I'm sure all of you have that experience because it is really a thrilling experience to get out the tumor. Sometimes when it is very deep, adherent to structures, when there is bleeding and you're not able to control it, then I ask myself, why did I go into orbits? Why did I not stick with cataracts? It would have been much easier. I wouldn't have encountered the bleeding. But then after the tumor is out and you have control, there is not much bleeding, then yeah, you do. I do feel like a Superman. I'm
And
sure.
I feel like a Superman the next day when the movements are good and the vision is good.
I think
Yeah,
that is better.
like a Superman, Dr. Ruchi. At that time, I feel like a Superman. Absolutely right. I mean, it's the thrill cannot be. No other thing can duplicate that thrill.
See, doing orbit is always a very pleasing experience. If you do it successfully,
Huh.
because
It
see,
is scary while you're doing. It is very pleasing after it's done. And
yeah,
like Ruchi said, it is very good the next day.
yeah, because see, I've seen very people senior like Dr. Betharia, who is actually pioneer of oculoplastics. So once he was operating and doing, but it was just explore and nothing came out, and ultimately it was just like exploratory orbitotomy, and then he has to close. So this came out to be pseudotumor later on. So it was because that time imaging was also not that good, which is there now, right now.
Yes.
But this happens. So removing the tumor when you are attempting it nicely, successfully, and of course with the preserving the vision, of course it gives a lot of pleasure.
Yeah, without damage. Yes, absolutely right, sir. I'm sure it echoes with all of us. And I remember my teacher, Dr. Subramaniam, sharing that his teacher, Dr. Vengal Rao, used to just do orbital surgeries on the orbital venogram.
Yeah.
That is the imaging they had available. And I really wonder how they would do it, how he would have done it. But maybe it would scare less because you can't really see how close the tumor is to the important structures, so you can go in more boldly. Maybe, I don't know. I always wonder.
I think we are blessed with the imaging techniques that we have, the contrast,
Yes,
the
totally.
DWI, the diffusion weighted imaging, and then almost like 70% of the times we have a diagnosis before we go in.
Yeah.
So we are
Absolutely.
well prepared of what we are dealing with lately. So yes, I think that's the era of oculoplasty, the evolution.
So that time when it was started, then people used to say that orbit is a Pandora's box. So it was very challenging and very courageous people only will start doing orbit.
Yeah. Now that feeling is reiterated with my transitional cell report, but I don't know. I'm just waiting
Okay,
after I
but
get the
just
tumor.
just inform us that what came out.
I will definitely let you know, sir. That I'm waiting. It may be another week by the time I get the report because I don't have the IHC at my hospital. So I'm just waiting on it. And they take time for the reagents to give the report. They take a little time.
Okay, so great to have such a wonderful discussion on the history as well as the new things in oculoplasty and orbit, especially. And let us proceed with the next presentation. Before the presentation, I will be introducing Dr. Sonam Nisar.
Um, Doctor, can you click on the presentation, please? Just open the presentation and share again, doctor. It's already shared. Just minimize the window and go to the presentation, please. Ma'am, you're muted.
Oh, are you talking to me?
Yes, ma'am.
No,
I have no presentation. I'm
No,
on.
I'm talking to Dr. Shalmali.
yeah, he's talking to me, ma'am.
Okay, but it's
Yeah, I
showing
was.
my
Yeah,
screen.
ma'am. Can you just minimize, doctor? Can you just minimize the window and open the PPT?
Yeah. So, can you see the PPT now?
No, ma'am. It's not visible as of now.
See,
Or
then
you can just open the PPT and then reshare, please.
Oh, shit. Can you see the PPT? Not yet.
Yes, please. Just make it full screen, doctor.
Yes. Okay. Finally. Okay. Uh, Dr. Sonam Poonan Nisar. She has completed her basic medical education from the SDM College of Medical Sciences, Dharwad, and her master's in ophthalmology from Mamta Medical College, Telangana. She did her research cum clinical fellowship in orbit oculoplasty, aesthetic and reconstructive services at Shankar Nethralaya, Chennai. And currently, she is a consultant at Shankar Nethralaya, Chennai, and in charge of the oculoprosthesis clinic. She has special interest in ocular trauma, orbital infections, management of thyroid eye disease, aesthetics, and socket surgery. She has many publications to her name. So, with that, we'll proceed with uh, Dr. Sonam's presentation.
Thank you. Thank you so much, Shalmali, for that kind introduction. And I'm just going to share my entire screen now. So, is my screen visible?
Yes.
Fantastic. So, yes, at the outset, I'd really like to thank AIOS for this fantastic initiative, Dr. Santosh and the entire team at AIOS for this, GuruSangam. All right, good evening. So, well, my topic for today is ABC of thyroid eye disease, and this is a very basic overview of the entire thyroid eye disease spectrum that we actually see. So, what is thyroid? Okay. So, well, the outline is going to be that I'll be giving a small brief introduction. We discuss the pathogenesis, the risk factors, clinical features, and the management outcomes. So, well, thyroid eye disease is also known as Basedow-Graves disease, and it's an autoimmune inflammatory disorder that is predominantly seen in the women in the 3rd to 5th decade. Though it is predominantly seen in women, the severity amongst the males is much higher. Thyroid eye disease can cause debilitating disease of the orbit and the adnexa in the form of functional disability, distressing changes in appearance. Sight-threatening disease can be seen in 3 to 7% of the patients as well. So basically, it requires a multimodality treatment because the thyroid eye disease can be independent of the systemic thyroid or can coexist with systemic thyroid. And this is one thing that we need to really explain to our patients very clearly. So, well, the pathogens is that it is an autoimmune condition, and you have the TSH receptor antibodies along the insulin growth factor 1R, which actually stimulates the antigen presenting cells. In turn, that stimulates the helper T cells, B cells, causing a release of the Graves' disease immunoglobulins on one side, and on the other side, it also helps in causing an autoreactive T cell, which targets the fibroblasts in the orbit. Now, these fibroblasts are not just present in the extraocular muscles, they're also present in the adipocytes in the orbit. And that is how it causes adipogenesis, as well as it causes a sequence of reaction, causing a release of GAGs, imbibition of water, and causing extraocular muscle enlargement, as well as adipogenesis, as you can see here. So that is a basic etiology of pathogenesis that we see. Now, disease types, because of this, is two. Mainly, either you have a predominantly fatty type, or you have a predominantly muscle. Now, what we commonly see is the predominantly muscle or a good mixture of both of them. Very seldomly do we see a predominantly fat prominent disease. As you can see here, this is an MRI scan. You can see on both the sides. On the left side, the scan is more of a fat dominant disease. You don't really see so much of enlargement of the extraocular muscles, unlike the pictures on the right side where you see that there is a tendon sparing enlargement of the extraocular muscles. So imaging plays a very key role in identifying this type of a disease process. So what are the risk factors? The risk factors is race. That generally they say that the Caucasians have a much more severity compared to Asians. Females obviously are more predominantly seen, but severity is higher in men. It's seen generally in the third to fifth decade. Patients who have undergone radioactive iodine therapy, who have a positive family history, presence of TSH receptor antibodies has been associated with a more severity of the disease process and dawn. Yes, there are some modifiable risk factors, and that is something that we tell all our patients. Smoking actually stimulates the hyaluronic acid production and increases adipogenesis. It also causes recalcitrant thyroid eye disease. It does not respond to the standard immunosuppressant therapy that you're giving. Even tobacco chewing is contraindicated in these patients. And smokers with Graves are 7.7 times more likely to develop a thyroid eye disease as compared to that of non-smokers. Yes, selenium deficiency is controversial, is debatable, but selenium also helps in protection of the oxidative damage and metabolism of thyroid hormone and can be given in mild thyroid eye diseases. Yes, pardon? Hello? Okay, right. So there has been a recent study which shows a high correlation of severity and cholesterol or lipid profile. So nowadays, this lipid profile as well as high cholesterol levels along with the thyroid eye disease is gaining more important. And I think we had a talk on this, a beautiful session by Dr. Marian right in the morning. Also, life stressors also play a very important role in thyroid eye disease. So we all are very well versed with the Rundle's curve. That was the first paper which actually spoke about the duration of the thyroid eye disease, wherein Rundle's actually studied like one family or one patient along the whole course of thyroid eye disease. Now, we all know that this may or may not be correct for all of our patients. Hence, we have to give a very tailored approach when we're actually treating these thyroid eye disease patients based on the symptoms and signs. So, based on Rundle's curve, there are two phases. One is an active and one is a quiescent phase. So, once the patient has an active phase, it generally lasts for anywhere between 6 to 24 months. In quiescent phase, you see more of fibrosis, whereas in active phase, there is more of inflammatory signs. And there will be progressive proptosis. The inflammatory score will be much higher. If you do an imaging, you'll see a lot of fat stranding. You'll see hyperintense signal within the muscle. There will be unstable squint or diplopia, and it can also lead to optic nerve compression. Whereas in the quiescent stage, you'll see more of fibrosis. It will be more stable. It will be T2 hypointense signal on imaging in the muscles that indicates fibrosis of the extraocular muscles. The squint or the diplopia also will be stable. So that is how you can actually distinguish between an active and a quiescent stage clinically as well as based on imaging. However, this graph may not be valid for each and every patient. Now, when you're looking at a thyroid disease, you actually look at a lot of signs, right? So you look at the soft tissue signs, you look at the lids, you look at the extraocular motility, you look at proptosis. Very important not to miss is your ocular surface and the cornea as well. So, well, we all know, let's go more details into each of these signs. So, soft tissue signs are basically where it's because of what? It is basically because of the increase in the adipogenesis in around the orbit. So, when you look at a patient, so thyroid eye disease can either be unilateral or bilateral. And we know that this is the most common cause of proptosis in adults. It could be unilateral or bilateral. So now if you're looking at a unilateral disease, it's very easy to pick up because you're comparing with a normal eye. But sometimes bilateral diseases can often be missed. So what do you see? You see from the eyebrow right till the cheek. You look at the subbrow fat, brow expansion. You look at the subbrow fat increase in the fat volume. Then you look at the lid retraction. You look at caruncular edema. You look at soft tissue signs like chemosis, conjunctival chemosis, or periorbital fullness, edema, like I mentioned, upper lid, lower lid fat prolapse. Very important. Thyroid eye disease patients will also have a lacrimal gland enlargement and can present with a lacrimal gland prolapse as well. And that is something that we must definitely distinguish from any other pathological cause of a lacrimal gland enlargement. Now, what is a cause of congestion? Basically, there's an increased hyperemia because of all the gags that are released there. And there is increase in the orbital fat with increased intraorbital pressure, which can cause conjunctival chemosis. Now, eyelid signs, we all know, are basically because of the fibrosis and the contracture of the levator palpebral superior muscle and the inferior rectus muscle. Also, the secondary cause of fibrosis will be because of overaction due to hypertropia or hypotropia. Sympathetic activity of the Muller's muscle is one of the causes that can also cause lid retraction along with the lateral flare. So basically, when you look at the lid position, it's very nice, beautifully almond shaped. But here you will see that laterally it is plateauing, and that is what is called as a lateral flare. So you have an upper lid retraction, you can have lower lid retractions, you can have lateral flare, you can have superior and inferior scleral show. What happens is because of the contracture of the muscles, when the patient is looking down, there will be a lid lag and down gaze. And also when you try to pull the upper lid retractors down, there will be quite a tautness that you feel in that eye. Obviously, because of so much of lid retraction and proptosis, there can be lag of thalamus as well. Proptosis or exophthalmos, as we call it, generally they are bilateral or they can be asymmetrical as well. And you generally measure them with Hertel's exophthalmometer, or you can just do a direct wormhole view or Navziger's view examination in case you don't have an exophthalmometer. Very classical method, you can even just take a normal scale, put it on the lateral orbital rim, and also measure the amount of proptosis that is there. Now, what is the cause of proptosis in these patients? Mainly the orbital tissue proliferation, deposition of glycosamine glycans that lead to edema, and increase in the extraocular muscle volume and the orbital fat as well. All of these lead to proptosis. Now, secondary to proptosis, also we can have lag of thalamus, restriction of extraocular muscles. So extraocular motility is very, very important to be assessed in thyroid eye disease patients. Now, extraocular muscle involvement, as we all know, there's a beautiful mnemonic for it. It says, I'm so lucky. And that stands for, basically, you commonly see like first inferior rectus, followed by medial rectus, superior rectus, lateral rectus, and last you see the obliques, which are enlarged. But however, if you see an isolated muscle enlargement, then superior rectus LPS is the most common muscle complex that is seen to be enlarged in thyroid eye disease patients. Now, the extraocular motility restriction can be either mechanical or it can be secondary to fibrosis. So it can be restrictive, strabismus, and diplopia. In inflammatory stage, basically is because of the edema of the muscles, and later in the quiescent stage because of the fibrosis, as I mentioned. Now, there's a very interesting sign that we all have learned about. That is a differential IOP. That is something that we must assess in these patients because a secondary glaucoma can often be missed while treating the active stage of these patients. Now, Braille sign is basically an intraocular pressure increase by 6 millimeters of mercury or more on attempted gaze. Most likely because inferior rectus muscle is the most common muscle that is enlarged and thickened, we look at it in up gaze. So you measure it in primary gaze, up gaze, or even abduction, adduction, and depression, depending upon what gaze of the motility is restricted. Next, we have to look at the cornea and the ocular surface also. There is an interesting outreach of how there is a high association of thyroid eye disease with dryness, thyroid eye disease with moving gland disorders as well. And that is interesting to look. We all know classically that superior limbic keratoconjunctivitis, punctate epithelial erosions are commonly seen with thyroid eye disease. However, secondary to lag of thalamus, we can see keratitis, corneal exposure changes, and sometimes even a dreadful complication of corneal ulcer. So it is very important to look at the ocular surface to see the amount of lag of thalamus, how is the bells as well. Now, important thing here is not to look at the lag of thalamus only in active ways, like asking the patient to look and close the eyes. Also, we need to assess the nocturnal lag of thalamus, and that we can ask by asking the patient's attenders or relatives to just share a picture of the eyes when the patient is sleeping. Right? And the most common cause is basically because of, like I mentioned, because of retraction, proptosis, lack of thalamus, and then exposure changes. Now, for the PGs, yes, this is the most common question that is asked for by all of us for the PGs in an examination. And there are 19 thyroid eye disease signs, which the postgraduates and the fellows also must know. Now, just for the simplicity, I've divided them into upper eyelid signs generalized, and upper eyelid, lower eyelid signs, extraocular movement signs, facial signs, pupillary and conjunctival signs. Not going much in details of this, but it's very classical. The most common ones that we see is like Kocher's sign, which is a staring appearance. Lid lag and down gaze is von Graffi sign. Lid retraction is Darrell impulse sign. Then you have incomplete or infrequent blinking, that is a Stellwerk sign. Now these are like in your face, like you can pick them up the moment the patient is walking right at you. Joffrey's sign is something where you see absent lid crease on the forehead in up gaze as well. And other signs you have to look more deeper in order to assess. But like once you look at a patient of thyroid eye disease, you know this is TED that you're dealing with. So this is something that is necessary for all postgrads and fellows to know. Now, very, very important. Yes, we have done a clinical assessment and a differential diagnosis of a thyroid eye disease. How do you look for activity? Activity is not just based on clinical signs, but also radiological activity is very important for us to start our treatment. Earlier, ultrasound orbit was done to look at the thickness of the extraocular muscles, but it is quite obsolete now. You can do computed, you can do a CT, but generally in CT with contrast only, then you will be able to know the activity within the muscles. We generally prefer a magnetic resonance imaging, that is an MRI, because that's a beautiful tool for soft tissue assessment. We do CT scans generally to understand the bony architecture, and especially it's a fantastic tool in pre and post operative assessment after you've done a decompression. Now, MRI, what is the importance and why is MRI such a classical tool? Because it gives you a measure of not just the extraocular muscle enlargement, but also the fat hypertrophy, tells you about the fat effacement around the perineural area also, which is an indicator of dysthyroid optic neuropathy. It detects the apical crowding and early optic nerve compression, as it's already mentioned in multiple papers about the Barrett's index. MRI is one of the best tools to understand the same. Very, very important that it's an evolving concept of the radiological activity. So when you look at the radiological activity, you have T1 T1 and T2 weighted imaging. When you see an extraocular muscles, you see T2 intensity, that means there is activity in the muscles. But also when you look at the fat, you see the dirty fat appearance, that is the second part of it. And a diffusion weighted imaging also will tell you about the amount or imbibition or the cellularity which is there in the extraocular muscles. So these are the tools that help us also understand about the radiological activity. It also helps us in monitoring response to treatment, like especially if you're doing like or planning a radiation for these kind of patients, it will tell you whether there is an activity or no, and whether radiation is going to help in these patients. Now, coming on to the Barrett's index, we all know that more than 67% of the index is indicative or specific for an optic nerve apical compression. Now, how do you do it? Basically, in the retroorbital space, you measure the length of the superior muscles, as I have marked here, the superior rectus and the inferior rectus muscle, that is A plus B, and you divide it by the entire length of the orbit from the superior orbital rim to the inferior orbital rim. And multiply by 100, the index that you get, that is one part of it. Similarly, you do it for the horizontal muscles, medial rectus and the lateral rectus muscles, divided by the entire length of the orbit from the medial orbital wall to the lateral orbital wall, and multiply by 100. Whatever percentage you get, that's your Barrett's index. As I mentioned about the periocular fat effacement. So if you look very clearly here, you will see that around the nerve, the fat effacement in the right orbit in the lower picture is much lesser as compared to that in the left orbit. If the lesser the fat effacement plane which is there, then there is a higher chance of optic nerve compression. So that is another beautiful tool. Now for the PGs, it is very important for us to know the classifications. Now earlier we used to use no specs, Verniers classification, but now we moved on to either modified no specs, task scoring, that is Moritz, visa inflammatory score or ITEDS classification, and Ugogo severity scale. Ugogo severity scale is the most commonly accepted and most commonly we use that. What we use in our institute is the visa or ITEDS form, which is very easy to fill up. So V stands for vision, I for inflammation, strabismus, and appearance. Now the beauty of visa is it also tells you about, or it has a scoring for active phase and inactive phase, as well as your quality of life. And this is a follow-up form. So you can compare at every visit when the patient is coming, how much the improvement is seen at every visit. If you see very clearly in the top right, you have an option to even look at the quality of life scoring system in this visa inflammatory score. And that is really important for our patients because a very severe Graves' disease can actually reduce the QOL for these patients. Now, Ugogo classification has divided TD into mild, moderate, and severe. And that is based on the amount of lid retraction, proptosis, soft tissue enhancement, and whether it is involving the vision or not involving the vision. Now, often missed in these cases is look at this patient. You see, this patient looks very normal. There's not much proptosis. There's just a very subtle subraw fat prolapse, which is there, or expansion of the subraw fat, very mild lower lid retraction. And if you see, the right eye already has a corneal exposure, scarring, and all the sequelae possible of an exposure keratopathy. Now, this was a case of a shallow orbit, and that can often be missed. Now, these patients don't present with very classical proptosis. They may just be looking like a normal patient, but you have to assess them more closely because shallow orbits are often associated with dawn. And the same thing happened in this patient. If you see, she actually had a dysthyroid optic neuropathy, but hers is a more fat disease as compared to an extraocular muscle disease. She underwent a decompression for the same. Now, there is something else that is very interesting. Now, when you look at this patient, he's come to you with all lid retractions, conjunctival chemosis, exposure changes, and everything. But when you do a simple imaging, what do you see? You see a fantastic, beautiful, dilated superior ophthalmic vein. So often CCFs, which drain anteriorly into the orbit, that is a keratoconcavenous fistula, can be confused or can be misdiagnosed as a thyroid eye disease because superior ophthalmic vein dilation can also mildly happen in a TD patient, and that needs to be differentiated from a CCF. So a neuroimaging would be ideal in these kind of patients. Now, coming on to the management, yes, mild, moderate, severe, and light sight threatening. So, mild is very, this thing, we don't really have to do much, just lubricants, home vision monitoring. You can give them some selenium antioxidants and behavioral changes like in terms of diet, regular monitoring of the thyroid function tests if they have deranged TFT. Now, moderate to severe depends on whether how symptomatic the patient is, the amount of proptosis, and diplopia and extraocular motility restriction, and your CAS score or visa inflammatory score. So IVMP would be like the first drug of choice in these kind of patients. What we do is we follow a pulse IVMP pulse therapy that is 500 milligram weekly for 6 weeks. And if they respond to that, then we taper it down to 250 milligram weekly. If they are not responding so well, or if they are steroid responders or dependent on steroid, then you can always change to an immunomodulatory therapy or immunosuppressants like an azathioprine or a mycophenolate mofetil as well. If you have a sight-threatening disease, that is a dawn. Very, very important to do all your optic nerve function tests, diagnose dawn correctly, and then start immediately an IVMP, that is intravenous methylprednisolone 1 gram for 3 days, and then plan your further mode of action based on the response to the initial IVMP and severity of vision drop that is there. Now, those patients who do not respond to steroids or steroid dependent, we can shift them and give them radiotherapy or immunomodulators, as I mentioned, or even subject them to orbital decompression based on the severity of the disease. So that is the baseline or the broad protocol that we followed. But like I said, a thyroid eye disease patient can respond differently to different therapies, and each and every case is different. So a very tailored approach is very important in these patients. Now, for a dysthyroid optic neuropathy, obviously vision, color vision, even contrast sensitivity, if you have the chart, is very, very important. In fact, contrast sensitivity is the first to actually drop down in the case of any optic nerve pathology. Vision fields at Humphrey's vision field 30-2. As you can see, imaging also is very classical of optic nerve compression. The Barrett's index is almost 88%. In this case, the fields are very much compressed here. And the VP is also showing a delayed P latency as well as a reduced amplitude. So here we start the patient on 1 gram IVMP for 3 days. Now, in patients with active TED, when you want to plan something which is not for, like, if you don't want to give further steroids or something, then another fantastic option is also radiation. So you can give an EBRT, that is an external beam radiation therapy, or you can give an IMRT or IGRT also. We give generally 20 grays in 10 fractions. Each fraction you can give only 2 grays, and the beauty of it is you give posterior to anterior. So when you're giving posterior to anterior, the dose that you give is not at all toxic to the optic nerve or to the retina as well. But it is very, very important before you give radiation, you have to do a thorough fundus evaluation. Make sure that there are no diabetic retinopathy changes. So our contraindication or cutoff is patients who are above the age of 35 years, not responding to IVMP, and those who do not have any DR changes, when we do give them radiation. Radiation in active phase is fantastic because it prevents the morbidity that can happen in the fibrotic stage, or if you wait till the active TD becomes quiescent. Most of our patients with radiation, we've been able to avoid any squint surgeries or decompressions also. Now, surgical consideration, as I mentioned, is obviously the activity, the vision, cornea, thyroid status, and imaging. It's imperative that we actually first, the thyroid gland evaluation and the systemic thyroid has to be assessed for in all of these patients. Now, when do you advise a decompression? So, medical management is very clear. Now, let's go on to when you advise surgical interventions or when do you do surgical interventions in these cases. There are difference in both active as well as inactive phases. So in inactive phase, mainly what you do is more of cosmetic and to reduce the amount of diplopia, whereas in active phase, it is basically to salvage the vision. So both the decompressions are technically different. Now, if a patient who's already on IVMP, if the patient is worsening within 1 to 2 days of starting your IVMP, no response for 1 to 2 weeks after giving IVMP, in those cases, we would, and there is a severe vision deterioration, then we advise a decompression. Now, decompressions are two types, fraud and broad. Fraud is basically fat removal or vital decompression, which is reserved for the cosmetic part of it and mainly for the quiescent stage. Whereas broad is the bone removal or vital decompression, which is required in active stage. Now, what are the indications? As I mentioned, is dawn, which is not responding to treatment, severe proptosis with exposure keratopathy, intolerance to steroid, and vision less than 660. In those cases, we will start IVMP and then plan orbital decompression. Now, here is the patient on the right side where she has shallow orbits. She was not responding to IVMP, and we did decompression. And look at that, beautifully it settled down within 2 weeks of decompression for her. So we have four walls in the orbit. The most common decompression you do when you want to do in an active stage with dawn, that is discharged optic neuropathies, you have to address the medial wall as well. Now we prefer going into medially with an ENT, with a colleague, that is ENT, this thing with an endoscopic approach. Along with that, you can do a balanced decompression, that is a deep lateral wall decompression also, which has been beautifully described by Dr. Robert Goldberg. So that ways you can do a balanced decompression. If required, depending on the type clinically how it is, you can also do a floor along with the medial wall decompression. Very seldomly roof decompressions are done, but there have been articles describing an all four wall decompression for thyroid eye disease patients. However, I have no personal experience with that. So now, what are the guidelines for deserved proptosis reduction based on the degree of bone removal? So basically, orbital fat removal can give you about maximum 2 millimeters of reduction in the proptosis. Fat plus lateral one can give you up to 4 to 6 millimeters. Now you do fat plus 2 wall will give you 6 millimeters. Fat plus 3 wall will give you about 8 to 10 millimeters. And if you do all 4 wall, you can have a reduction in proptosis of as much as 10 to 12 millimeters as well. So as I mentioned about the technique, we prefer to go for the medial wall by endoscopic approach. Laterally is basically via lateral canthotomy along with the transconjunctival incision. If you're doing the keyhole, that is a superior lateral orbit, and if you're doing a decompression in that area, then we would prefer a lid crease approach. And if you're going for the floor, then a transconjunctival approach. Previously, people have done transantral and transcutaneous also, but we prefer more of minimalistic or aesthetic approaches there. Now, it is very important to understand when you're doing a medial wall and a floor, there's one structure that should not be touched because that will cause a hypoglossy, and that is the strut. That is the inferior-medial strut, as you can see in the pictures and marked beautifully with the arrows. And also, we should be well aware of the neurovascular bundles that are there around the orbit. Now, obviously, post decompression, there can be a couple of issues that can happen. If you're going endonasally, like Dr. Ruchi beautifully mentioned, when you're doing an orbital surgery, it's always amazing to tap the muscle in the vicinity of the area that you're working in so that there is minimal damage to the muscle. When you go endonasally and you open the periorbita there, you see the muscle which is generally enlarged and they won't be in the normal position most of the times because they're so thick. So in case you're not taking a proper incision, you can actually cause a damage to the muscle. And never, never do we take a vertical incision when you're going endoscopically. You always take two horizontal incisions. And also if you've tacked the muscle, you can pull the muscle so that your ENT colleague has a good visibility of where the muscle is and she can plan her incision accordingly. In active phases, basically, there's generally a lot of bleeding because there's more of inflammation. So a good hemostasis is very much mandatory in these kind of patients. Other than that, when you're doing a floor and a deep lateral, you have to be very well versed with the infraorbital vessels. Other than that, laterally, there are no major structures, so you can beautifully go ahead and do the decompression. Now, what we prefer is there are two things by which you can do a decompression. The old chisel and hammer mallet is not really used anymore. Either you can use a burr, electric burr, you can use, or a drill, or very tissue friendly is an ultrasonic aspirator, that is a sonopet, and I'll be showing some videos on that later. You can see here the patient, this was an interesting case because she had an active TD which was not responding. You can see only her inferior rectus muscle is slightly enlarged and there's a hyperintense signal there. You can see there's conjunctival chemosis, but when you look at her orbit, this is basically a shallow orbit with an active TD and more of an orbital fat component compared to an extraocular muscle disease. So she underwent a decompression. You can see pre and post operative pictures, and she's doing fantastically well. Now, there's another thing when you're looking at a patient where there's an active TAD, there is lag of thalamus, corneal exposure, and a melt, as you see in this case. What do? First, foremost, you have to close the lids. You do a tarsorrhaphy. Most of the tarsorrhaphies in these cases will give way. So what we prefer is this drawstring tarsorrhaphy that you do along with giving IVMP and treating the corneal melt or corneal ulcer. This patient eventually had scarring of the cornea, underwent PK and was doing fantastically well. So that would be another pointer that you can do drawstring tarsorraphies in these patients because the intraorbital pressure is so much that the conventional tarsorrhaphy generally tends to give way in these kind of patients. Drawstring tarsorrhaphy is good because you can remove the drawstring and also at the same time instill the topical medications for the cornea. Now, coming on to the quiescent phase. Now, there is a proper schematic approach that we follow. First, you do the orbital decompression. Then you see the kind of strabismus that is there and address that. And then finally, you do a lid adjustment. So as you see in this patient, she actually presented with this. This is a primary gaze photo where the eyes are like having hypertropia and stuck there. We did a very nice inferior medial wall decompression in this patient. And finally, you can look at the lid position post decompression picture. In fact, with this, we could actually prevent any further strabismus correction also for her. So, like I mentioned, a tailored approach, what wall are you going to approach is very, very important in each and every case. Now, the deep lateral decompressions, as we know, it's more done for the cosmetic cases, and you can get a good proptosis reduction of about 4 to 6 millimeters with just this. So you have in the superior temporal quadrant, you have the lacrimal keyhole. Then you have the orbital door jamb, and then you have the basin, that is the lateral aspect of the inferior orbital fissure along with the lateral wall is what you can decompress. Along with that, you may or may not combine it with a fat removal, and this gives a fantastic result. You can see here, this is a fantastic article by Dr. Robert Goldberg et al. And we did the same for one of our patients doing well. So this is an ultrasonic aspirator. We've taken a transconjunctival incision and we're going in with an ultrasonic aspirator. Now, the beauty of the sonopet or the ultrasonic aspirator is it has a bone drill and a soft tissue drill. So it does not exothermic like a standard burr or a electric drill that you have. B, the bony drill that you have or the bony tip that you have, it only causes the bone or it will work only when it comes in contact with the bone. It doesn't cause any further damage to the soft tissue. So that's the beauty of these tips and I really like it. You can see here pre and post decompression immediately on the table. You can see a good response and that's how we assess on the table when to stop. So that's another thing. Now, this is another patient. You can see pre and post decompression. He had a very long follow up. He's undergone almost 2 decompressions. And yeah, this is a beautiful picture that has been already published in IJO by Dr. Nayak et al., which actually tells you of all the important structures around the orbit and that we should take care of while addressing or doing a decompression. So when you're doing a transcaruncular approach, the lacrimal sac is the only structure which is there. But most of the times we go retro sac. So we generally don't end up damaging the sac or the canalicles. But it's fantastic to for PGs and fellows to understand the important structures and its correlation with the globe. Now, here is another patient where you see she had only a fat disease. She had a very mild mild disease, basically about 3 millimeters proptosis only was there in her. And all that we did was we did the transconjunctival approach and the fat which is there was just decompressed. What I do mainly in all my patients is the amount of fat we put in a syringe to understand how much of fat we have removed from each eye. And that helps when you're doing a bilateral decompression. And only then you can do like a justice when you're doing a bilateral decompression. It should not be like from one socket, one orbit, you're removing more fat compared to the other. Otherwise, you get a lot of asymmetry in that case. So, well, those were the approaches for decompression. And yes, there are newer drugs that have been described in literature that work beautifully. And with the advent of teprotumumab, which is an insulin growth factor inhibitor, you can actually, they work fantastically in active phases in dawn, and they respond beautifully for active proptosis as well. So in literature has said that the rates of decompression after the advent of medical management like teprotumumab, rituximab, tocilizumab, and belimumab actually have come down. So that is something that would be worth to be noted. And coming on to the quiescent stage, now once you have actually dealt with the proptosis, you have a lid retraction, which I would call as glare, flare, and stare. So it is basically because of the fibrosis of the LPS and its aponeurosis, because of the fibrosis and adhesions of the orbital septum, fatty infiltration, and as I mentioned, sympathetic simulation of the Miller's muscle, as well as secondary cause of lid retraction is because of fibrosis of the lower lid retractors. This is one of the famous questions for all the postgraduates that we ask. So yeah, that would be worthwhile to note. As you see, look at the imaging of this patient. If you see, it's only the SRLPS complex which is so thick, and she has a very gross lid retraction. So when you're looking only at a lid retraction, what I prefer to do is I also prefer to do an imaging to look at the activity in the SRLPS complex before planning what kind of treatment that we would like to do. So lid retraction has a classification. You grade it as mild, moderate, and severe based on the amount of MRD1 or the superior scleral show that is there. Now, in mild cases, just a mullerectomy generally suffices. In 2 to 3 millimeters of retraction, you can do an levator recession along with the mullerectomy, or you can even go in for a full thickness blepharotomy. Now, why I said imaging is very important is because if the muscle is very fibrotic, you might have to do more than what you have planned. Whereas if there is activity, then I would not go in directly, because now you have a choice of giving intralesional tricot injection for these patients with lid retraction as well. I'll come on to that if I have time for that. And also, if you have severe lid retraction, you will have to do a bigger levator recession along with division of the lateral horn of the levator. Actually, disinsertion of the lateral horn of the levator muscle actually helps in correcting the lateral flare also. You can do a graded full thickness blepharotomy, and that's one of my favorite go-to surgeries for lid retractions, especially which is more than 3 millimeters. More than 5 millimeters, you can do a full thickness graded blepharotomy, Z myotomy, or you can even put a spacer graft. Now, these are just few pictures from different textbooks that actually state that you can do a posterior approach or an anterior approach for the correction of lid retraction. If you want to do a levator recession, then you have to use an anterior approach. If you're only dealing with molars, then posterior approach is more than enough. If you're doing a Z myotomy also, an anterior approach will give you a better look. Now, what interesting that we do is we do an upper lid mullerectomy along with excision of the tarsus and the conjunctiva, and use it like a spacer for the lower lid, especially when you have an upper lid and a lower lid retraction. So just look at this patient pre and post op. In one sitting, we were able to correct almost 70% of her retraction there. Anterior blepharotomy is a beautiful technique, and that has been described by Leo Kurnev. And you can see this patient has responded so beautifully, and you can see the amount of lid retraction that he had. Now, one important pointer here is that you must keep your upper lid traction sutures for at least 5 to 7 days, because already in a quiescent stage, there is going to be fibrosis. And if you release the upper lid traction suture early, then the eyelid will go back to its position and your blepharotomy might actually fail. Now you have the non-surgical management for lid retraction that I was telling you. Look at this patient, managed her very beautifully. She had a very subtle SRLPS hyperintensity. All I did was I just gave her an injection tricot into the upper eyelid transconjunctival approach. And look at her after 3 months. She looks the upper lid retraction is beautifully settled and she is quite happy. This was done because even her TFT levels were not in control and there was a little activity in the muscle complex. Hence, decided to do a tricot. Now, there has been a role of fillers also, because they also act as spacers. They also help in stretching the posterior lamella there when you inject it transconjunctivally. They generally last for about, like, depends on the type of fillers, 6 months to anywhere between 1.5 years as well. And yeah, you must monitor these kind of patients. So like I mentioned, it has to be given in the between the posterior lamella and the anterior lamella. So basically at the level of the orbital septum, if you're giving there. Like I said, it just is utilized as a spacer. Now, another thing that is very beautiful for cosmetic rehabilitation, especially in quiescent diseases, you can see this is a patient of inactive TD in quiescent phase, you see the lateral flare, you see a lot of fat prolapse, lower lid fat prolapse, transconjunctival fat prolapse. All he wanted was his under eye bags and the transconj fat prolapse in the superior temporal quadrant to settle down. And look at him post-operatively. He's doing excellently well with the surgery. This is a transconjunctival approach. So basically, to conclude, the ABCs of TD is a detailed clinical assessment, history taking very important. When the patient walks in, you look at all the signs. If he's a smoker, you must ask the patient to stop smoking. Also ask if they've undergone any radioactive or iodine therapy or any thyroidectomy. In detail assessment, basically. Then it is very important to stage the disease, whether they are in the active phase or the inactive phase, and a tailored management. What is the symptom? We address that and we treat them according to that. So I'd like to thank my department for the same, and thank you so much for the opportunity again. I think the
Thank you
slides
so
are-
much, Dr. Sonam, for an excellent
Yes.
lecture.
Thank you.
And
Congratulations, Sonam, on a very comprehensive presentation. So proud of the strides you've made. I remember you as a SR, and now look where you are. Excellent, very good. Your hard
Thank
work
you.
is really, I mean, we can see your confidence and hard work in the way you present. And I just wanted to add a little thing. We had a paper on triamcinolone in active phase of thyroid lid retraction. When the disease is in the active phase, the triamcinolone given subconjunctivally into the LPS works really well, not just by reduction of the lid retraction alone, but also by the other inflammatory signs which are going on in the muscles or some of the orbital soft tissues. And almost with one injection, 90% of our patients had very good relief. We repeated a second one if they did not give a positive response within 1 month. But it was we had a good series of almost about 30, 40 cases. That was a thesis I gave one of my postgraduates, and really it was, I mean, is the go-to drug for me now for thyroid lid retraction in the active phase.
Yes, ma'am. I completely agree. I think it works beautifully if there is an activity, and like you mentioned, in the active phase. Also, I think when we're giving this, because it acts as a depot, it is very important to also monitor the IOP
Yeah,
weekly
we
for
did
safety.
find IOP rise, Sonam, for the first day, about 8 hours after the injection. We admitted those patients just to check the IOP, and then it magically went down. There was no IOP rise after that. None of the patients developed any kind of IOP rise or glaucoma after that.
Nice.
I find it better than Botox because botulinum was used, but it has a very variable result.
I agree. Botox actually does not, we cannot predict the
Yeah, we
response.
cannot predict whom it will act. So I've almost abandoned botulinum, and my go-to is triamcinolone.
Thank you. Thank you so much, ma'am.
yeah, good to know. Any other comments from any of the other panelists? Any questions for Dr.
Yes. We had a very, very, very elaborate presentation. She did well.
Yes.
I think it was too lengthy. But anyways, she has presented very well and covered all the aspects. So I think good to listen. Thank you.
Thank you. Thank you.
Okay, thank you. And thank you so much, Sonam, for an excellent comprehensive presentation. And we will move on to our next presentation. But before that, please let me introduce our presenter, Dr. Bhagwati. Uh, uh, can you see my PowerPoint screen?
Yes.
Yes, okay. Dr. Bhagwati Vadvekar, she is currently Professor of Ophthalmology, Sri Manakula Vinayanagar Medical College and Hospital, Puducherry. She has a professional experience of 24 years, MBBS from Gandhi Medical College, Bhopal, MS Opthal from Shams Shah Medical College, Rewa, Fellowship in Orbit Oculoplasty and Oncology from Arvind Eye Hospital, Madurai, and worked as an oculoplasty and cataract surgeon in various charitable hospitals, including the Indira Gandhi Eye Hospital in Lucknow and Seva Sadan Eye Hospital in Bhopal for 8 years. Vasan Eye Care Pondicherry for 2 years. Pondicherry Institute of Medical Sciences for 8 years, and currently working as a professor at SMVMCH for more than 2 years. She was awarded the FAICO by AIOS in 2013 and worked as a Vice Dean Research for 2 years in Pondicherry Institute of Medical Sciences, active member of the Ethics Committee at her current workplace and in the past as well, and an executive member of the OPI from 2021 to 2023 and present. Executive member of the POA. She's also a AIS, DOS, and TNOA member. Worked as president of Scientific Society at PIMS. And for those who regularly go to OPI, know her for her excellent dance performances as well. And today she will be presenting on management of painful blind eye, a rational approach.
Thank you very much, Dr. Shamli, for that wonderful presentation. I'll share my slide.
Yes, please share your presentation.
I hope it is visible. Is it in
Yes,
slide?
yes, it is visible now.
Yeah. At the onset, I'll like to thank Dr. Santosh Munawar and entire team of the program for giving GuruSangam for giving me this wonderful opportunity. So I'll be talking about the management of the painful blind eye. So blind eye is the one with the visual acuity of counting finger or the worst that has no realistic possibility of recovering the visual function. Sometimes, despite of all the efforts from our side, the vision is permanently lost and the eye undergoes degenerative changes, which leads to the loss of the vision. And then we have to counsel such patients that they cannot recover the vision, but we can give a pain relief and we can give a good cosmesis so that they stop running from the doctor to doctor and spending their time and money, and we can give suitable treatment. Most common etiology for this is neovascular glaucoma and also the other forms of the glaucoma, such as angle closure glaucoma, trauma, that is chemical trauma or physical trauma. And however, the corneal decomposition is also very important cause for the painful blind eye due to the corneal bullae and corneal abrasions. Then corneal inflammation such as chronic uveitis and also the chronic retinal detachment. Then secondary ocular infections such as keratitis and the endophthalmitis. So these patients are actually have a very poor quality of the life also, and they present with a shrunken, non-functional and icicle eyes most of the time. All cases of the blind eye, you need to take a detailed history and do a detailed examination, and then you have to do the relevant investigations to find out the cause of the blindness, whether it was local cause or whether it was any systemic cause. As the patient is one-eyed now, and if there was some systemic cause for the blindness, such as CRAO, CRVO leading to the neovascular glaucoma, so we need to find out these causes and we have to ensure that the patient is taking treatment for these so that he doesn't develop the blindness in the other eye. And we have to explain the poor prognosis in the present blind eye and explain the risk of the vision loss in the other eye so that the patient keeps on taking his medication and keeps on following at the proper time. So currently there are not much of the set guidelines that can specify how these patients should be approached. But this is a proposed treatment which I got in the IGO publication 2023. And so we should do a thorough clinical examination, which includes the fluorescence staining of the cornea and taking the IOP and slit lamp examinations for the cells and flare. And if the patient has the pain due to the increased IOP, then you need to use the pressure loading drops, topical steroids, and the cycloplegics. So if patient doesn't get relief from this, then we can suggest some cyclodestructive procedures, such as cyclocryotherapy or the cyclophotocoagulation. So cyclocryotherapy can cause like great hypotony and sometimes the phthisis bulbi and the sympathetic ophthalmia. Cyclophotocoagulation is still better alternative, so which we can first treat the 180 degrees. And if the sufficient amount of the IOP reduction is not achieved, the other half can also be treated. In spite of this, sometimes the patient will have the pain. And then we can use the retrobulbar alcohol injection, which is ethanol 2 ml 96%. Or a better alternative is also available, which is chlorpromazine, which is 20 milligrams per ml injection can be used. This causes the irreversible changes in the ciliary ganglion and causes the pain relief. So pain relief is about 80 to 85% with this treatment. So after this, even if patient doesn't get the pain relief, then the last resort is evisceration here. Again, if the patient has the pain due to the corneal surface, then we can give the lubricating drops, therapeutic contact lens, topical steroids. And if the patient, if this not relieved, then the conjunctival advancement flaps, such as Gunderson flaps, can be done. And these flaps protect the tear proteolytic enzymes to come in contact with the cornea and prevents the cornea. It helps in the vascularization of the cornea also and reduces the sensitivity of the cornea. So at the later stage, if patient wants osmosis, then we can put the shells. We can put the stock shell over the vascularized cornea because it is less sensitive. And if patient has a bulle, you can go ahead with the anterior stromal puncture with the antibiotic and bandage contact lens. And if this doesn't work, again, here the resort is retrobulbar injection, and then last resort is evisceration. Similarly, if the patient has an inflammation due to uveitis, we can give topical steroids, cycloplegic drops, and if not relieved, then the proposed treatment is to give the IV intravitreal steroids. In the dose, about one single shot can be given in the vitreous. And if patient doesn't get relief, again, retrobulbar injection can be given. And if all this doesn't work, the last resort is evisceration and enucleation. So, but we have to put, when we are clinically seeing the patient, we have to tell them about evisceration and enucleation while we are putting them on the conservative treatment so that they are mentally and emotionally, they are prepared for the enucleation and evisceration. Now, this is a patient who had the painful blind eye in the right eye. The vision was PL negative, and the IOP was around 30 millimeters Hg on the maximum anti-glaucoma therapy. We also did the cytophotocoagulation, but the patient did not respond. So we went ahead with the evisceration with the implant for this patient. These patients, painful blind eye, not only the pain is there, but the another concern is also cosmesis. Like the cosmetic concern can arise either from the corneal opacity or a bicycle eye or anterior staphylum. So you have to make sure whether the patient, which is the main concern, patient, whether it is a pain or it is cosmesis. So if pain is only the concern, we can go ahead and treat the, like previously we have discussed in the previous slides. But if the cosmesis is also the concern, we can advise evisceration and enucleation at the earlier stage also. Now, if there is a painful blind eye, which is having corneal opacity and the globe is of the normal size, and patient main concern is pain, then we can give only the conservative treatment as described previously. And once the pain relief is achieved and the cornea is smooth, we can, and patient wants cosmesis after that, then we can give a cosmetic contact lens trial. If the patient tolerates the contact lens well, we can continue the contact lenses. If patient doesn't tolerate, then we can do corneal tattoo. In case the cornea is irregular and antistaphyloma is present, then we can go for evisceration with the implant. But in case the antistaphyloma is more larger and posterior, then we can do enucleation also in such cases. If from the beginning the patient wants both cosmesis as well as the pain relief, then we can directly go for evisceration or enucleation with the implant. In case the B scan shows intraocular malignancy, then we should do enucleation with implant. Evisceration is an absolute contraindication for such cases. Now, this is a girl who was having the anterior staphyloma and pain. So conservatively, we controlled her pain and then she wanted the cosmesis also. So went ahead with the evisceration with the implant for her. But if the staphyloma is bigger and the posterior, we can do enucleation also for such cases. Now, how to manage the physical and painful blind eyes. So first we have to control again the pain, and after controlling the pain, if patient wants the osmosis, then you can do a shell trial. You can ask the patient, you can put these shells in the patient eye and then ask the patient to sit for 10 minutes in your OPD. And if you tolerate them well, you can continue those stock shells. And if they are not matching the eye, then you can send them to the optometrist to get a custom head prosthesis, to the ocularist for custom head prosthesis. If they are not tolerating these shells, then you can go ahead with enucleation with implant. Now, this is a lady which having the pain in her right eye, and she wanted cosmesis also. So we controlled her pain, and later we gave her a shell trial, and she was tolerating it nicely. You can see her cornea. This is slightly whitish, and there is conjunctivalization of cornea also. So her cornea is actually less sensitive, so she was able to nicely tolerate these shells, and we asked her to continue the shell. Now, this is another gentleman. You can see the cornea is quite clear here. We gave a shell trial. This patient, the cornea was very sensitive and he was not able to tolerate the shell. So we went ahead with enucleation with implant in such case. You can see this ptosis preoperatively, which persisted post-operatively also. So later we planned for doing the ptosis surgery for this patient. Now, when to do enucleation and when to do evisceration, it depends upon the ocular condition and it also depends upon the surgeon and the patient. The absolute indication for enucleation is the intraocular malignancy and a badly traumatized eye which cannot be repaired. And another advantage of enucleation is that there is no fear of sympathetic ophthalmitis. Now, evisceration is preferred by most of the oculoplasty surgeons because it is very simple procedure. And it gives it is less complex, it is very quick and less of the bleeding is there and gives a very good implant motility. So we can do this evisceration in staphylomatous eye, blind eye. It is anterior staphyloma, we can do evisceration. If it is very big posterior staphyloma, then we can go with the enucleation also. With endophthalmitis, we can do evisceration. In panophthalmitis, there are two schools of thoughts. So first, some people like to do evisceration because it is quick procedure, and but it is always better to control the infection and give IV antibiotics for 2-3 days before planning for evisceration in such cases. So this is a lady which we did evisceration with implant. So first we gave antibiotic to her, IV antibiotics for 3 days, controlled her infection, and then we went ahead with the evisceration with the implant. The other school of the thought says that they prefer doing the enucleation for such cases because the optic nerve sheath, it can transfer the infection to the meninges. And sometimes there is also fungal infection, fungal endophthalmitis, which can be retained in the sclera. In all cases of expulsive hemorrhages, we like to do evisceration. Now, intraocular malignancy is an absolute contraindication for the enucleation. But we should also avoid enucleation in multiple other places, such as severe trauma, because here the uveal tissue is very much adherent to the sclera and very difficult to remove. Similarly, we have to avoid enucleations in prior VR surgeries are there. And these eyes also have the silicone oil in them, so it is difficult to do. Imaging is not very optimum, and we may miss sometimes some tumors. So it's better to avoid evisceration in such cases. Whenever you have a very young child, less than 6 years, or a very elderly, then you avoid evisceration in such cases because they can have malignancies. In case of severe phthisis, you should avoid evisceration because we won't be able to put an optimum size implant in such cases. In the case of mild phthisis or the minimum phthisis, we can do evisceration with implant, but not in the severe phthisis. Similarly, if you see extensive calcification, you should avoid the evisceration because it can be retinoblastoma or other malignancy. Now, before doing enucleation or evisceration, you should always make sure what are the patient expectations, whether it is only the pain relief or it is osmosis, and do a B scan in all the cases, particularly when the fundus cannot be seen. Also try to do a UVM, which will help not to miss the anterior tumors. And in some case of physical eyes, the B scan is not very helpful. In those cases, you can go ahead with the CT scan or MRI scan. All cases send the globe after enucleation for histopathology, mark it appropriately, and send all the eviscerated contents for the histopathology. Now, these are the different types of implants which are available in the market. These are non-integrated implant. So they don't have pores, and so they don't get integrated with the orbital tissues. This two are semi-integrated implant. You have to pass the muscles through this hole and then suture it. These porous polyethylene and hydroxyapatite, these are the porous implants, which will allow the fibrovascular tissue to go through this, and this will get integrated with the orbital soft tissues. Now, which implant is best for the patient? If you are dealing with any intraocular malignancy, it is always good to have the silicone or the PMMA implant, because these if there is recurrence of the malignancy, then you need to give radiotherapy. These are radio-resistant. And secondly, if they can be easily imaging, it is very easy to identify the recurrence with these implants, then hydroxyapatite implant. So these implants are also only preferred. In case of children, if you are putting a small size implant and if you want to change it later when the child grows up, then these implants are better, because you can easily remove these implants, while it is very difficult to remove a hydroxyapatite implant without damaging the ocular tissues. And these are also cost-effective implants. Now, where do we place the implant? In case of the evisceration, we put it into the scleral shell, whereas after enucleation, we are putting it into the orbital fat or the intracorneal tissues. Now, this is a patient. You are seeing superior sulcus defect here. So, if your implant is a small size, this can give rise to the such defect. This will give rise to a superior sulcus defect, and also the not very good implant motility. If the implant is a larger size, it can cause the extrusion of the implant. So we have to get an appropriate and optimum size implant. Now, how do you calculate the implant size? So the volume of the globe is 7 cc. And when we do enucleation, we create a deficit of 7 cc. So we have to replace it. 4.5 cc is replaced with the help of the orbital implant, which is 60 to 70%, and about 2.5 cc from the prosthesis. So this 4.5 cc actually corresponds to 20 mm of the implant. So ideal size of the orbital implant for the adult is 19 or the 20 millimeter implant. If you are doing it in a child, you can use slightly smaller, that is a 16 to 18 size implant. In case of enucleation, if you are doing evisceration, then you are putting the implant in the scleral cavity, and the relatively required size of the implant will be smaller. And usually the 16 size implant is very good, and it is safer in case of evisceration, and which will allow us to suture the implant without any tension. In case you want a larger size implant, you want to put 17 or 18 size implant, after evisceration, then you have to do the relaxing incisions in the sclera. Now, this is a small tip. This is a video by Dr. Santosh Hunagar. So I'll be sharing just few tips about enucleation. So give a lateral canthotomy, then do a 360 degrees peritomy without damaging the conjunctiva, and then separate the tenons, both anterior and posterior tenons in between the rectus muscles. And then hook muscle one by one, first medial rectus muscle, and then pass a silk suture just short the insertion, and about 6 mm from the first suture, you tie a mitral suture. These sutures will be utilized later. The silk suture will be utilized for putting the traction on the globe, and the mitral suture will be used for tying it to the conjunctiva. Then you take the inferior rectus, then medial rectus, then superior rectus, and then you separate the oblique muscles after cauterizing, particularly the inferior oblique muscle. Cauterize and then cut it. And then you give a traction. You can give a relaxing cut on the conjunctiva so that the eyeball will be prolapsed easily through between the blades. You give a traction and give a relaxing cut to the conjunctiva. and then pass a blunt scissor, tenotomy scissor, between the lateral rectus and the globe, and try to palpate the optic nerve. And thus, along the optic nerve, you try to reach the orbital apex. And just anterior to the orbital apex, you cut 2 millimeter anterior to orbital apex, cut the optic nerve, and try to cut in one shot, so that it doesn't damages the structure at the apex. So this is a technique by Dr. Santosh Hunawar. This helps in taking the long stump of the optic nerve and also not to damage the apex structures. After that, we can put an optimum size implant and then suture the posterior tenons, and then pass those vicryl sutures tacked to the muscles, and just short of the fornix, you have to tie these sutures, which will provide the motility to the implant. And then you need to cover it with the anterior tenons and then posterior tenons. Anterior tenons and then the conjunctiva. And then put a conformer. So if it is a case of retinoblastoma, you have to take a long stump of the optic nerve. You have to examine the eyeball from all the sides and mark it and send it. Then this is a few surgical steps about the evisceration. So you have to do a 360 degrees peritomy and then take out the conjunctival button and then remove the entire tissues, uveal tissues. You have to take the tissues en masse and not remove it bit by bit. In spite of doing this, sometimes the tissues will be left in the sclera, and then you have to scrape and remove everything. In the end, you can use an absolute alcohol to denature these tissues and then put an appropriate size orbital or appropriate size implant, and then suture the sclera and then suture the conjunctiva. And do not forget to send for histopathology. Now, if you want to put if you are doing the evisceration in case of the mildly thicical eye, then you can give a relaxing incisions. In between the rectus muscle, you can give relaxing incisions like this. And similarly, there are the other incisions which are described in the literature. This is equatorial incision, which will help to accommodate a larger sized implant. Similarly, this is a flower petal technique where you can make the sclera into the 4 petals and then you can suture them. This will help us to accommodate a larger size implant in case of mildly thicical or moderately thicical eyes. This is again a posterior sclerotomy which can be done. So again for accommodating a larger sized implant. So these patients with a painful blind eye, they are already too much exhausted with the all treatment. You have to counsel them properly. And while you're putting them on the conservative treatment, you need to tell them that there may be a possibility to remove the eye so that they are prepared mentally and emotionally. And you can put an optimum size implant and give a pain relief to these patients and good cosmesis too. Thank you very much.
Thank you, Dr. Bhagwati, for an excellent presentation. And do the expert panelists have any questions for Dr. Bhagwati?
Wanted to congratulate Dr. Bhagwati for a very extensive presentation. She's covered almost every aspect. Just wanted to ask the panelists and Dr. Bhagwati also, do you have an experience with implants in panophthalmitis and endophthalmitis? Because I am very hesitant to place a foreign body in an eye which is already infected. I would do conservative methods, wait for the pan or the end to subside, and then go ahead after it becomes thicical or just pre-thicical with the implant.
Actually, I have done it in few cases, madam. So most of the cases it came out very nicely, but usually for 3-4 days we like to give an antibiotic for such cases.
Because I don't put any foreign body all with the infection already there. So I would like the other panelists also. So
I
to
will
share
also
their
like to
wish.
add this, if the patient is immunocompromised, like sometimes patient has a CKD and they already prone to infection every time. So it is better not to put in such patient
Absolutely.
prone to infection.
Absolutely.
The best of thank you very much for a very good presentation, Dr. Bhagwati, and you have covered almost all the aspects. But actually, as the question is that it is able to put any foreign foreign material if the eye is infected in any way. So it is the only secondary implant which is advisable in these cases, and the best time to put it after a week. So in between, we can on the table we can do a antibiotic lavage, and of course antibiotic systemic for a week with the peptidase and anti-inflammatory. And just after a week, because after a week time is very good enough to take care of the local infection and the systemic infection both. And then, because if it is very late, then of course the fibrosis and retraction of the sclera is an issue. So that time the sclera at this becomes little, sometimes it becomes short. So that is the thing. So best time is in these cases to do after 7 days.
Actually, I think
my
Dr. R.C. Gupta sir, we are having a slight issue listening to you. There is some problem with the connection. Can everyone else hear him clearly or
It's
not?
not audible, it's breaking.
there's a
Yeah,
network
Yeah.
problem.
yeah. Dr. R.C. Gupta sir, we are having a network issue. We're not
Okay,
able to
okay.
hear you clearly. Now we can hear you, actually. No, we still have an issue.
Am I audible?
Yeah, you're
So now
audible
we're
now,
audible.
sir.
Am I audible or not? Your
You're
voice is clear
audible.
to me.
You're audible,
Yeah, that's
but
okay.
your voice was
Okay.
getting cut like a network issue in
Okay,
between.
okay. So what I was telling is that putting the sutures in the with the implant and the sclera are in case of evisceration, or with the muscle in case of enucleation. I prefer to put nylon sutures inside, and the conjunctiva is sutured by the vicryl. So that is my way of doing it, because what I think is that the suppose something happens inside, so it should not get exposed, or it should get extruded. So to avoid that, that is the best part. Another thing is that it is always better to do evisceration as much as possible if it is not contraindicated. Of course, if it is tumor, or if it is malignant, or anything like that, then of course we cannot do evisceration. But the implant is retaining is better, and its movement also better in case of putting the implant in the eviscerated eye rather than enucleated eye. So this is what I want to add.
Okay, sir.
I want to raise another, anyone else? Sorry.
Actually,
Else on-
yeah, I think, ma'am, that's a fantastic question that you've raised, because we regularly do, even in panophthalmitis, endophthalmitis, we do put a PMMA, polymethyl methacrylate implant, and success or the extrusion rates have been very minimal so far. But we look at the sclera. If there is a scleral abscess, if the sclera is very friable, then we do not put in a ball implant in the same sitting. So we do make the posterior sclerotomies, we do all of that, because the point of doing evisceration generally, basically, we want to reduce the infection load. So we do it, and like Dr. Bhagwati correctly pointed out, we do give post-operative antibiotics in these kind of patients. So only if the sclera is okay, we still remove a 2 mm frill in PANOF patients, because sometimes they do have scleral abscess. But the sclera is really bad, then there's a higher risk of implant extrusion or further rejection of the implant. But as a protocol for all patients, we generally do EVISC wall implants. Yes, we've had surprises, like Dr. Bhagwati mentioned, like fantastic talk, Dr. Bhagwati. Like it's a painful blind eye. It looks like it's infected because there's a corneal ulceration when you open it. You're like, this is not normal. And there would have been probably a pre-existing history of a choroidal melanoma. I mean, we have had a couple of cases and had to convert an EVISC into an enucleation for these kind of patients. But otherwise, we generally do for most of our patients at the same sitting. And Dr. R.C. Gupta, fantastic point. So, in case we don't do an ball implant, then what we prefer to do is we put a gauze piece inside, which is soaked with betadine, keep it for 1 day, and then we remove so that the sclera is not really contracted, like you correctly said. So, because after that,
That's,
secondary surgery becomes a little challenging. So, yeah,
I
thank
think
you
that
so
is
much.
another way of doing it. And in case of thiacical eyes, na, so in thiacical eyes, because sclera is already shrunken and it is little bit retracted. So what I do is, in those cases, just for the sake of my practice to be extended to the other audience practitioners, that I don't remove the whole button of the cornea. I remove the endothelium and the epithelium, and the just use as a part of the sclera, so that I use it as lengthened sclera, and I use it there. So usually in those cases you can put better bigger implant, which is actually other would not have been possible if it is removed, the button is removed.
Very interesting point, Dr. R.C. Gupta. I have not seen it being done.
Mm.
Maybe we should talk later privately and
Yeah.
ask for your videos or whatever, where you're leaving a part of the stroma from what you said, removing the endo and the epi, and leaving a part of the stroma, and
Yeah.
you use it as a flap to cover.
Yeah, actually, there are two ways of to use it. Because if it is more fibrous, then we can use it as a part of the sclera. And if it is not that, then what I do, I cover the suture line, which is over the sclera. I cover it with the giving a reinforcement of exposure, prevent exposure of those sutures.
Okay.
Thank you, sir, for raising this thing. Actually, when cornea is opaque, actually, we can leave it. It is also less sensitive and we can use it as a cover.
And I do betadine lavage. Good betadine lavage also is peaceful to see the post-op patient.
I do
And
alcohol, pure alcohol for, all the uveal tissue, if it's left behind, like you said, where there's adherence sometimes, when you can't take it out like a mass, I make sure that is absolute alcohol for a little while in the scleral shell before placing the implant.
Okay, I have a question for Dr. R.C. Gupta.
Yeah.
Sir, have you had any of your patients who you had planned for a secondary implant, like they're lost to follow-up or something? Have you had any such issues?
No, fortunately, it never happened to me.
Okay.
Because actually in UP there are very few people who are doing but the biggest spectrum, large spectrum. So that may be the reason, because very few people are doing it. So patient usually I get is from other colleague, ophthalmic colleagues referral we're getting. So most of the time patient are not lost.
What I've observed is, especially in government institutes, if the patient is coming from a very long distance, they are not keen to come back after 1 week or such. And so sometimes there are those issues with respect to a secondary implant with special
Actually, there some patient who are very far from very far off distance. We keep them waiting for wake in the ward itself. Otherwise, the patient who are coming from nearby, we discharge them and they will come back again.
That is an excellent way of managing, sir.
Yeah.
Yeah, we also keep them admitted, and people are very motivated if you're going to give a good cosmetic outcome. So they will come back. I mean, you have to sort of impress upon them the cosmetic outcome. Now, I have another question to raise here about placing a conformer, placing a prosthetic eye shell on an thiacical eye. Because what we often see, those eyes come back to us about 15 years, 20 years later with very bad fornices, and the prosthetic eye does not fit anymore, and then you have to go in, do a enucleation, and then use a I don't prefer in those cases really an silicone or this thing. I use a dermis fat graft. I'm a big advocate of dermis fat grafts. They do very well. Movement is less, but the volume is very well replaced. And the patient who already has a bad fornix and the prosthetic eye falling off at awkward situations, awkward times is quite okay with not having entire movement transmitted to the uh, prosthetic eye. So dummy fat graft we have to do. So I just am I'm wondering whether at the first go, if the eye is very thiazical and does not permit you to place a proper sized implant in the scleral shell, should we go for a primary dummy fat graft instead of
Ma'am,
placing a
there are
eye on top of that eye?
there's some variables of the clinical conditions like physical eyes which intend to have inflammation frequently, or even infrequently, even sometimes maybe in a year or so, in once 1 year or so. Those eyes are not actually should not be subjected to put give processes, because anything the disease itself is something is going on inside. And I think that is, it is always better to enucleate or eviscerate, as the case may be, and put the implant, and then give the process. That is the best. This is the best solution. Some people who are having very quiet eye and they never have had inflammation in the eye, and they are very comfortable and there is no cornea which is sensitive. In those cases, yes, because sometimes patient are not willing also. So in that cases, yes, we sometimes advise those patient the prosthetic eye, and actually they go well.
Because of
I've
the
just
yeah.
Sorry, ma'am. I'd just like to add a small point. I think here in these kind of patients, what we've observed is that shell care is very important. Like they have to remove it periodically and clean it. If they're cleaning it, then there's no problem generally, because what happens is there's still a concavity on a thiazical eye. So there is still collection of tears, mucus secretions, and that itself incites an inflammatory reaction there. So if we properly counsel them regarding like a stock shell, proper care, I think then the chances of contracture, bad circuits are much lesser. Most of these patients don't remove these eyes for many years together because they don't know how to clean it, or they're scared about it, or they have a taboo. So I think that awareness to clean the stock shells on a thiazical eye, I think that would really prevent this kind of a scenario.
Your point is right. Good. His point is good. But nowadays, the prosthetists, these ocularists, actually, they make very good processes, very
Yes.
customized processes, and usually they recommend that patient need not to remove it very frequently. But still, if on recommended intervals they remove and clean it, it is always better for the socket health.
Yes,
I think
especially in a tricycle, I sir, because it's like a constant process. Sometimes it like we don't know when it is going to shrink further. So yes, sir.
Okay, so I have a question. So, um, if you have a patient who has previously had trauma and the eye has gone into phthisis, like sutured and this and everything, so would you prefer to do a enucleation with implant in this patient, or would you?
Yes,
Yeah.
yes. We'll prefer to get the uveal tissue taken out, and then because in traumatic cases we should not take any chances.
Okay.
if it is a corneal repair, I would definitely go for a evisceration. I would just take out the cornea and do the routine evisceration type. But like sir said, if it's very badly traumatized, posterior tears and all, then maybe we have to sacrifice the globe and do maybe you could even do a frill like thing, leave a frill and then place. Yeah, now another third controversial point I want to put out to the expert panel here is dermis fat graft versus silicone or PMMA implants in a enucleated socket.
Ma'am, to my experience,
What are your preferences?
to my preference, actually, I always prefer silicone implant, because I have put before PMMA, before that the polyethylene plants, lot of implants I have put, but the best in my hands actually the silicon implant work, and that too the 16 number is a very universal, and this is very well taken most of the eyes. Because 18 number and 20 number to my hands they have not been successful. Most of the time they got excluded. So that is the thing. And even I make a frill, I make the double busting of the skull flaps also, but still sometimes they have got the exposure, and actually they extrude. So the silicone implants, they work very well.
I have one question for
I was
Madam.
wanting to know in the
Madam.
enucleated socket, sir. After you remove the eyeball, whether there is no scleral shell, whether you want to place a artificial implant or a biointegrated implant like a dummies fat graft.
Ma'am, before, because the dermis fat grafts actually indication has been in the contractor socket before. Okay, so usually we don't put dermis fat graft in place of in the place of the implant. So that is for increasing the volume of the orbit, basically. Here we have to fill the volume of the orbit. So that is the difference. Actually, dermis fat graft has been used by for the expansion of the socket. So that was the indication, basic indication, because ultimately the fat will absorb, and whatever fat you'll put inside, that will go. It is ought to reduce, and usually it is seen that is the 1/3 or half to 2/3 fat is absorbed in the long run. So if you are putting in the dermis fat graft in place of implant, it ought to have a reduction, and of course, ultimately, the eye will the process which you'll fit in will actually become ill fit after some time.
Yes, I also wanted to know actually from Modini Madam the long-term follow-up
Yeah.
of your cases with dermis fat graft.
Of
Have you done
dermis fat
long-term
grafts.
follow-up for
Yeah,
people?
I have they do very well in my hands. Adults especially do excellently. In children, sometimes there is a liquefaction and the graft becomes bigger because of a cyst, lipid-filled cyst, which you can just go and aspirate and then place a tight roller bandage over a prosthetic eye or a conformer on the eye and it settles down. I find in my hands it does good. Dermis fat graft does better than a enucleated socket, an implant in the enucleated socket, because
As
it
the
tends to
sir
migrate whatever you do.
suggested, as the
Whatever
sir,
you do,
as,
sulcus deformity comes.
yes. As the sir told that it absorbs after some time. So do you have any experience? Have you noticed it? Like,
Not really, not really. 90% or more of them have quite comfortably the dermis fat graft gets integrated in adults. I'm talking prosthetic eye looks good in primary position. Sometimes the sideways movement also is not very bad, because I realize it is the fornix which actually gives the movement rather than the muscles to the scleral shell. It's the depth of the fornix which I have been trying to evaluate, and how the contact between the deepest part of the fornix and the prosthetic eye, that contact is what transmits the movement to the prosthetic eye. So some of them have reasonably good acceptable movements as well. In children, definitely there is a little bit of a liquefaction of the fat, and sometimes they have a bulging. The prosthetic eye doesn't fit because it is the graft gets too big. But adults, no, I have not had any bad experience. It doesn't get infected. Only problem is that it takes longer for the dermis to conjunctivalize, and maybe they have to go without a prosthetic eye for maybe 3 months, 4 months, sometimes even more. That is the only issue.
I think that epithelialization takes time, but now
Yeah.
to enhance that epithelialization, we started PRP drops. They work beautifully, and you can give it to the patients, especially local patients. You can give them probably 2 courses, and it beautifully works, because in case of a traumatic eye already, there is a lot of fibrosis, there's a lot of scarring, there's a lot of process which is happening, which actually delays the healing. So in a DFG, this works very well if it's not a radiated circuit. So yeah, that is. I think.
Radiated sockets are another story. Totally
Yeah.
another. Can't do
So-
much there.
But
So
we've
how do
never
you get the PRP
time-
drops Sonam, do you prepare them yourself? You draw the blood and
No, not us. Our lab prepares it. They
I
only
mean, yeah, I mean your setup. Yeah, we don't have the facility to get that, but I would definitely would like to talk to you later on one-to-one basis to talk to your lab person and see if I can replicate it in my setting so that it will help the patients to be quickly using the prosthetic eye.
Modini ma'am, I would like to add for PRP that what is required is a centrifugal machine. And if you, with the help of the centrifugal machine, and you need one who will remove the blood, and you can make PRP. It is very easy actually. And
And how do you ensure the sterility?
Sorry?
How do you ensure the sterility because they have to use it for a while?
Yeah. So directly implant into the insulin syringe. I mean, you remove the blood, take it out, put it in the insulin syringe, and ask the patient give 10 insulin syringes and keep it in the fridge, and then he can use it in 1 or 2 weeks.
Okay, because we have a centrifuge at my center. I just have to take the I mean the biochemist on board and they have
It
to
is
do it.
doable. It is doable and very easy actually.
I
One less
shall see. I
centrifugal
shall
machine.
explore.
Yeah.
Okay, I shall definitely do it because that is the biggest challenge I face with my DFG, and I do a lot of DFGs. Almost every week, 2 DFGs, 1 or 2 DFGs. So I do a lot of them. I've migrated to a DFG after I have stopped putting these orbital implants because whatever you do, I'm finding them migrating. They're somehow migrating. I know the extra incision, the pain of but most of our patients, the people I get are from lower socioeconomic. They're all poor patients because it's a government hospital, not very concerned with scars on that part of their body because they anyway cover it with clothes, and they're quite all right with it.
I think main thing for PRP is that they have to store it at 4 degrees Celsius. So if they are from that low socioeconomic background, they don't have a fridge at home, that could be challenging.
It may be a
Because
challenge.
we
It
give it
may
to
be a
them in an
challenge,
ice
yes, I
box, which is a part of the package that we charge them. And we give it to them because a lot of them travel along with it.
Yeah, that may be a challenge. I'll have to see how to overcome that, or
And
maybe keep the
excessive
patient for
PRP,
a
yeah,
while.
and excessive PRP can also cause contracture. So it has to be correctly only in that thing because if we look at the platelets, it has a contraction, it has fibrin also, and it has the growth factors also. So that is, I think, the beauty of it. We are still trying to study that. How much is not too much?
And for PRP, second option is you take a 10 ml lubricating eye drops, remove 5 ml, put it inside, and use that bottle. Keep the bottle in the fridge, or use insulin syringes.
Yeah.
That is easier. They can carry that better. But like Sonam said, the ice pack is a challenge. But yeah, we can do something about that. We'll have to think ways and we'll have to think.
I think that's a great
So
discussion.
you people don't face any migration issues with silicone and PMMA implants?
I had one extrusion actually.
I think Dr. Bhagwati, you don't?
One case I had it. Actually, this was very small eye and I could not see the muscles properly in that case. So
okay. So you suture the muscles also after you suture the tenons?
Yeah.
Okay. So secondary, it is difficult to trace the muscles.
If you cannot
Same
identify
sitting,
the muscle, then it is difficult. Sometimes it is.
same sitting, it is possible. But if you're doing it at a later setting, say after a few years of that, then it may be difficult to identify the muscles. I shall retry again because all of your experiences is giving me hope. So I shall retry in 1 or 2. Maybe I'll give that as a thesis to my new PGs, incoming PGs. Dermis fat versus.
Icicle eye, ma'am, in icicle eye, I never had the extrusion. In the somewhere enucleation was done few years back, and in that I did a secondary implant. In that it was difficult to identify the muscles. That particular case I had.
So proper selection of the case. So maybe we'll have to do maybe next time we have this very interesting discussion and actually practical points. It's a very good discussion. Thank you all.
Thank you so much.
Yeah.
Thank you.
Anyone has any other questions for the panelists? regarding thyroid, the vascular malformations, any of the previous presentations?
We've had a fantastic discussion. I think just one point in painful blind eye is also to consider the psychosomatic status. Because sometimes everything is actually okay, but it's just that phantom pain or,
Yeah.
because of any neighboring sinusitis that they constantly will tell you about, like, pain only in the superior nasal quadrant or something like that. So I've had couple of cases, they don't want a removal initially, but even after removal, they complain of constant pain. And I think it's very important to assess these kind of patients pre-op, because managing that post surgery when there is nothing and you've treated everything according to you is challenging. I've
Maybe
had
you should
two
try
cases.
alcohol retrieval bar injection.
We've tried for 2 cases. Actually, that patient has probably gone to almost every possible oculoplastic surgeon that I know of. Also, we have seen it's a psychosomatic pain which is there. So I think sometimes for these kind of patients, it's also important to just that one aspect. I think we can look at as well.
Yeah. You have to assess your, in any case, whatever surgery you do, clinical assessment is the primary tool, which has to guide your management and your decision making. Very important.
So thank you everyone for wonderful discussion. All the presenters, our expert panelists, Dr. Modini, Dr. R.C. Shah, Dr. Sonam, Dr. Arundhati, Dr. Bhagwati, and Dr. Tarjini, who was there for a short while. And thank you very much for an excellent discussion. Thank you.
Thank you all.
Thank you,
It
Dr.
was
Shalini
well
and
spent Sunday
everyone.
evening.
Good night. Bye. Take care.
Good night. Bye-bye.
Thank
Bye-bye.
you.